Are we live? Well, hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, August 9th of 2026. It is time for another live IC support group meeting. These are for patients who have pelvic pain, bladder pain, prostate pain, pelvic floor dysfunction, pudendal neuralgia. We even talk about things like pelvic congestion syndrome, ovarian cysts, all sorts of things. You are welcome. If you are a patient or a family member or a friend of somebody who's got pelvic pain, I am here for you. I am definitely here for you. Now, we are live streaming on YouTube and Facebook, and we've just set it up. So we need to give it just a little bit of time here to let people come in. Make sure I set up Facebook okay. I think I did. All right. Maybe. Let me know if the sound is okay. Would appreciate it if y'all let me know that the sound is okay. Hello, it's Jill from the IC Network, just starting another live IC support group meeting. Hi, Sherry. It's nice to see you, hon. All right, now for you people on YouTube, you are historically a little on the quiet side. I would love it if you could introduce yourself and say where you're from. You don't have to use your real name. Also, please let me know if the sound is okay, because sometimes the sound gets a little bit on the funky side. It's been a day. It's been a weekend. So we're just waiting for people to come in. So let's just hang out. Hello, Michelle from Alabama. It's so nice to see you. I can just imagine that you are in the middle of a sweltering summer weekend. Yikes. It was supposed to be super, super hot here, but it wasn't. We've had the fog coming in, so it's a lovely blue sky out there. Heavy fog at night. Hello, Brandon. It's so nice to see you. I hope that you are doing well. I am in a funky mood today. I just have to say that, Saturday is my one day a week where I don't work, and I had a good day yesterday. I'm just out and about doing whatever I need to do. And then this morning I woke up and I felt like there was a disturbance in the force somewhere, it just felt like something strange was going to happen today. So I've been a little bit cautious all day. Yeah, very hot in Alabama. I'm not surprised. I am not surprised. So, I don't know what your guys' Sunday morning routine is. Mine is basically kind of staying in bed, although I don't sleep in a bed. I sleep in a recliner because of my TMJ. Oh my God, I have a hysterical story also. And so I was just reading and stuff like that and just kind of chilling for a while. And I thought, no, man, you got to get yourself up. Come on, get up, get outside, take a walk. Got to work on your fitness, all that sort of stuff. So I did manage to get myself up and do some gardening. But I don't know, man. It feels like a weird day. I don't know if it feels like a weird day where you are. It feels like a weird day here. Hello, Ann. It's nice to see you, hon. It's very, very nice to see you. So I have a lot. Well, I have stuff, not a lot. I have stuff we're going to talk about today, now I'm just gonna be real honest with you guys. Like I got nothing to hide. You know that. For those people who watch these meetings, or some people call it my show now, for the last 15 years, there's very little that I'm ashamed of, and it's very rare I'm ever going to hide anything. So I, like so many other patients, have anxiety. And my anxiety stems from the fact that I was attacked when I was quite young by a rapist murderer who raped and murdered my neighbor. And so I did not leave my home without fear for about 10 years. And it's a long, drawn out story. And, he's in Folsom Prison. He's going to be there forever, until his 90s for sure. But the legacy of that trauma is so commonly found in IC patients. For those of us who have widespread pain, for those of us who have chronic overlapping pain conditions, right? So for the patients who have IC and IBS and vulvodynia and TMJ and migraines, anxiety disorder, sensitive skin, wicked sense of smell, that is what we call our widespread pain phenotype. And this phenotype is all being driven basically by an injury to the central nervous system. And the common theme in my office, there were 2 conversations last week with patients that really just kind of imprinted on my heart. And these were older women, believe me, happens with men too, who definitely had chronic overlapping pain conditions for sure. Mix and match whichever ones they have. One in particular had IC and had migraines and had fibromyalgia. The other had pretty wicked irritable bowel syndrome along with IC. And then when I bring up the research about trauma, and the fact that, okay, for 80% of the children who grow up to develop multiple chronic overlapping pain conditions as an adult, there is a major physical trauma. Okay. It takes 14 days of pain to basically change the way the brain is functioning. Basically, it places this patient into a constant state of fight or flight, and they're stuck in fight or flight for years, if not decades. And the problem with being in fight or flight is that it amplifies pain throughout the body. And so it's a big deal to be in fight or flight. It's not normal. It's not healthy because your heart rate is up, your blood pressure is up, your muscles are tight. And it's not supposed to exist that way. It's supposed to be calm and relaxed. And then, if they didn't have a physical injury, then we start talking about abuse and bullying. And almost every single one of the patients go, that's it. Yeah, I was abused, or I grew up in the home of an alcoholic, or I grew up in a violent home, or I was not safe. The legacy of this is very, very interesting to me because I was attacked in 4th grade. Okay, I was young. And attacked several times through elementary school. And I ran to school as fast as I could, and I ran home as fast as I could because I never knew when I was going to get jumped and hurt. And then I developed vulvodynia in junior high. I developed IBS in my 20s and migraines and all that sort of stuff. And then really fairly wicked anxiety disorder. And of course, when you're the patient, you're just so freaking baffled. It's like, I just thought that I was being punished for something. I didn't understand why every year there was a new pain condition happening. I just didn't get it. And obviously I became very depressed, just like anybody who's dealt with something like what I dealt with, it goes through. There is depression. You're watching everybody else live a normal life while you're at home laying on the bathroom floor in pain, which is what I did for years in my 20s. As I've said, it's kind of a miracle. I graduated from grad school, but grad school was at night. I was okay at night. It was the mornings that were my problem. So I could go to grad school, and I was a straight A student in grad school. So, the mystery is solved now. I totally understand what happened to me. I totally understand that my brain was trying to protect me by making me hypervigilant. I totally understand that this was subconscious, not conscious, that I had no control over this. This is just literally how a child's brain tries to save that child's life. It's going to make you hypervigilant. You're going to be, for me, as soon as I woke up in the morning, I was scared. As soon as I left because back then we all walked to school. I became more and more hypervigilant. The closer I got to school, the worse it was. And when I was at school, I was panicking all day for years. For years. So I get it now. I totally know it was never my fault. I totally understand what happened. No shame, no blame. And the best part of my job is when I get to say to you, for those patients who walked a similar journey to mine. No shame, no blame, not your fault. The hard reality, though, is that our brain is now constantly trying to protect us. And anxiety is real. Like I said, I woke up this morning like really anxious, and I couldn't really figure out why. The only thing I could like relate it to was the morning of 9/11. I mean, like it was weird. I don't know, maybe I was reading the news before I went to bed, or maybe I was reading the news when I got up in the morning, but something really triggered me this morning. The other anxiety that I have is I have medical anxiety. I have always had medical anxiety. And that really goes back to when I was a kid and they were doing urethral dilations, hurting the hell out of me. Awake. And if there's one anxiety that is just like haunted me is not quite the right word, but that it's been very, very persistent. It's just the fact that I just really, really, really don't like going to the doctor. Now, I have got a great set of tools. I don't panic anymore. Back in my 30s, I used to have panic attacks before every doctor's appointment. I don't do that anymore. I know what to do. I know how to minimize fight or flight. I know the value of deep breathing. My stop sign, deep breath, minimize the thought that I've talked about so often from this anxiety management class that, I took. Absolutely life-changing. So I haven't had a panic attack since I was 35. Win, total win. Yet there's little anxieties. So anyway, here's my funny story. My doctor wanted to have me tested for sleep apnea. And I'm like, why? I have no symptoms. I don't wake up gasping for breath. And like I say, the only reason I get up at night is because I have to pee. I have plenty of energy all day. I'm not napping all day. There's absolutely no sign that I have sleep apnea other than the fact that I now have AFib. And that was from the COVID vaccine. Okay. So anyway, I'm like hemming and hawing. And finally, it's like, okay, I'll do it. And so it was Tuesday. I woke up Tuesday just like a bear, like, God bless America. I do not want to go to Kaiser. I do not want to do this. My appointment was at 2:15. I was cranky. I was a cranky bear all day. And the way that I personally cope with moments like this is that, like, okay, then I'm just going to get really dressed up. I'm going to be really professional, and I'm just going to walk in at a power pose, like ready to do it. So anyway, I get to Kaiser, and I'm in this waiting room with like 8 other people, and they called us all at once. We were all there for sleep apnea testing. And so we walk into this room and I'm going, well, what the hell happened to my privacy? Wait a second. Everybody in this room is going to know that they think I have sleep apnea. I am annoyed with that. So anyway, they do a little 5-minute presentation. It's a kind of a wristband that you wear that covers a finger. Not a big deal at all. Totally not worth the anxiety, right? Totally like, oh my God, why would you even worry about this? So freaking easy. So you do it all night. You wake up in the morning. You got to take it all off, put it back in the box. You got to drive back over to Kaiser to drop it off. And I'm like up at 6:30. It's like, okay, I'm done. Put it in the box, get dressed, run it over to Kaiser, drop it off. Done. Now let's see what the hell it shows. And I'm like, okay, don't have to go back to Kaiser anymore for this. Because the medical, I'm sorry, I just definitely have medical anxiety. And so, a couple hours later, Email, we're sorry. The device did not collect enough information to tell us if you have sleep apnea. You need to come do it again. I'm just like, that's like if there's one like really important lesson I've learned as I've gotten older is if don't make a mountain out of a molehill and don't allow yourself to get really upset about something that in the end might not even be worth getting upset about. I always say, listen, if there's something medically that's bothering you, like you find a bump or something that you're just not really sure what it is, like get your tush to the doctor. Don't sit on it for 3 months because you're going to worry about it for 3 months. That's not good for your mental health. Just go let somebody look at it. And 9.9 times out of 10, it's absolutely nothing, and you can just calm down. And with the whole sleep apnea thing, it's like, I told them, I said, I have no symptoms. We know what caused my AFib. I'm just not going to do this again. And I really legit, I'm probably not. If I do it again, maybe I'll do it late fall. But like, I'm done. I want to stay away from doctors. And stay away from Kaiser for a while. So anyway, that's kind of my funny anxiety story is that here I got myself all worked up about the sleep apnea test and do it. Piece of cake, nothing to worry about at all. And then darn it, the device malfunctioned. Like, what can you say? All right. Hello, Miriam. How are you, honey? Okay. So let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I have been doing this work for 33 years. This summer is my 33rd anniversary doing IC work from when I started my first support group, literally exactly 33 years ago this month. Longest serving IC support group leader in the world now. And I happen to love what I do. And my job is to bring you the best information that I can, research backed, that will allow you to look at your symptoms a little bit differently, look at your condition a little bit differently, especially if you're not responding to therapy. If you're not responding to therapy, then let's take a step back and figure out why. Because here's what our national guidelines say. Our national guidelines say, hey, you're getting worse rather than better despite being on the typical meds for IC. Maybe it's not a bladder disease. Maybe it's something else, right? And that we now know that 87% of IC patients have muscle issues. We now know that there are a whole bunch of other conditions that are supposed to be ruled out that are often not ruled out by doctors that are potentially treatable, like pelvic congestion syndrome, fungal infection, muscle injury, pudendal neuralgia, a neurogenic bladder, all sorts of different things. So, there is hope now. We're long past the days of thinking everybody has an incurable bladder disease. We know that that's simply not true. We know that IC is a pelvic pain syndrome for which there are many potential causes. Brandon said, did you ever take medication for your anxiety before you took the class? The only medication so I tried a bunch of antidepressants and I had side effects to all of them, and not little side effects, like big time heart side effects. So I could not take any antidepressants. They never gave me Xanax, but they did give me hydroxyzine. Hydroxyzine is an antihistamine that has a beneficial side effect of also being an anti-anxiety agent. And so I used hydroxyzine for probably 8 years off and on, really successfully. And the only reason I stopped it back then is because I developed the one really challenging symptom to hydroxyzine, which is what we call hydroxyzine dreams. So this medication, hydroxyzine, is a generic name. The brand name is Atarax or Vistaril. As an antihistamine, it reduces mast cell activity in the bladder, and that's reasonable. That's a good way to kind of reduce bladder wall irritation and inflammation. But what happens over time is that it starts to intensify your dreams. So if you have a good sex dream, it becomes the best sex of your life ever dream. Like I literally dreamed that I had great sex with every actor of the movie Young Guns. I didn't know I was into cowboys, but apparently I was. Okay, and I'll never forget, man, that was a great dream. It wasn't real, it was just purely driven by medication. But a nightmare can become a night terror, and that's what happened to me. I started having nightmares, and then they became very, very, very vivid nightmares, and like watching I don't even say what they were. They were really scary, where pets were being harmed and family members were being harmed. And as soon as it happened twice, I knew exactly what it was. I knew it was the medication. So I stopped the medication, and I've never had a night terror again. Lori says, love that dream. I know. I mean, I'm sorry. Kiefer Sutherland was the boss back then. I love, and Charlie, well, I don't remember if Charlie Sheen was in that or not, but sorry, I've always been a Kiefer fan. So Sherry here says that she had nightmares after taking hydroxyzine too. Hydroxyzine dreams are a very, very well-known side effect of hydroxyzine. And you have to remember that you don't have to live with bad side effects. If a medication is interfering with your quality of life, if a medication is harming you in some way, then that means that maybe that's not the right medication for you. I would never have continued to take hydroxyzine after that happened, because it was, torturous. All right. So anyway, normally when I do these meetings, well, we can go anywhere from 2 hours to our most recent long one was 4.5 hours. That was a couple weeks ago. I'm here as long as you have questions. Normally when I do these meetings, I do a little intro, something that I want to talk about. And today it wasn't anxiety. Whenever I start these meetings, like I don't have a script planned. I just run with it. Whatever's coming up, I just run with it. Hi, Kathy. Nice to see you, honey. Hope you're doing well. Hey, you guys, if you can, why don't you put in the state where you're from? I'd love to see where you're from. So today we're going to talk about dealing with family members and friends who not only don't believe you, but don't respect you because you have IC. You have IC. And of course, the great challenge with IC is you can't see it. It'd be so much easier if this were a shoulder problem, right? It'd be so much easier if this were cancer, to be quite honest, because at least people hear the word cancer and go, oh, no. But when you say, hey, I've got interstitial cystitis, they're like, oh, okay, yeah, my grandma had that. She just drank cranberry juice and it went away. Or I can still remember somebody contacted me right after I started my first support group who said, you can cure that by drinking the juice of a lemon every day. It's like, yeah, you clearly didn't have IC if you were drinking the juice of a lemon a day. So when you have an invisible illness, when you have or an invisible injury that other people can't see, it's clearly much harder to explain it because you can't point to it. They can't see it unless you're lucky enough to have pictures of your bladder. And that's when doubts start to come in. There's always going to be that one person in the family who's just a little insulting. You're still going to the bathroom? Come on, just drink cranberry juice. Or I had a friend of mine, a former friend from high school, who was like literally with me the day my bladder pain started when I was 32. And like a year or two later, she said, I just think you like being in pain. You clearly need mental help. And I was looking at her going, are you kidding me? I am up all night crying my eyes out in pain. I don't like being in pain at all. This is awful. And, we were done. We were done. We are not friends. I walked away from that quickly. Brandon says here, yeah, people stopped caring and respecting you when you weren't getting better right away. I'm from North Carolina. Yeah. We've got somebody from Scotland, my favorite country, one of my favorite countries. Arlene's from Hudson Valley of New York. Sherry's Plano, Texas. Maria's from the Netherlands. Oh, listen, you know what? The Netherlands is a hot spot for IC research, I gotta say. We got Louisiana, we got Florida, we got California. Excellent. So, what do you do when you're at a table having a family meal or a vacation? Just a family vacation, and you just know somebody's going to say something disrespectful. If it's a difficult situation, and the way I used to just get really angry and upset. I mean, I've had people say terrible things to me over the kitchen table when I was much younger. I just are you kidding? Leave me alone. And I don't believe in arguing. I don't believe in fighting back. I don't believe in making a spectacle. I think that doesn't help. I think the people who win in the end are the people who are very calm and informed. And the thing is that you know your body. I know my body. They don't know my body at all. So if I have somebody challenging me, which hasn't happened in a long time because I can slam them with research, I think the very first thing I would say is, you know what the hardest thing about having interstitial cystitis is? It's just you can't see it. You just can't see it. And I know because you can't see it, you might not believe that it's there. But if you have it, this is when you whip out a picture of your cystoscopy. That would be great. It's like what you can't see is that I have injury. I have injury to my pelvic muscles. I have injury to my urinary tract. I've got injury to my bladder. I got injury to my nerves. And these are not little injuries. These are injuries that have me crying in pain when they flare. So as an example, let's say you're invited to a family party and you know that they're going to make something that you just simply cannot eat. Okay, so they're going to have sweet tea, which you cannot drink. They're going to have lemonade, which you should not drink. They're going to maybe have a hot, spicy barbecue, which, it's a little bit dicey. And there's nothing worse than walking into a family gathering and looking and realizing you can't eat a damn thing. So, what do? We bring our own food. We are the calm part in the storm. I understand my body. I know what it is. I know what I'm dealing with. I'm going to do everything I can to make myself comfortable. And that means I'm going to bring the food I might need. That means that I'm going to walk in with my confidence, with my head held high. And if anybody has a question about IC, I'm going to say, I'd love to tell you about interstitial cystitis. This affects 3 to 6 million women in the United States, 1 to 4 million men. It is often misdiagnosed as a UTI. Some patients have big bloody wounds in their bladder that hurt terribly. Others have big injuries, especially to muscle. And the challenge with interstitial cystitis is that we're often misdiagnosed. The challenge with interstitial cystitis is trying to find the right treatment that works for us. Now, I have been dealing with IC symptoms for 30 years off and on. And I will promise you that I am doing my best to live my life because I don't want anybody to have to suffer the way that I've suffered. So I thank you so much for asking. I appreciate your support. I appreciate your comfort. And if you're looking for any information on IC, there's a great website you can go to, IC Network. Or if you're prepared, you can bring out the IC diet guide if they have questions about diet. Right? We've got the whole diet list in here, along with a lot of articles. You can bring out the IC Flare Guide and say, hey, you know what? What's really interesting, remember that time we drove up to Tahoe and I had that horrible flare in the car? And what was devastating is the damn restrooms were snowed in and I was dying in pain. You know what that was? That was a pelvic floor flare. And now I know exactly what to do about that. I know I've got to relax muscles and I'm going to bring a muscle relaxant so we can go again. I'm not going to let that stop me. Now I understand what happened and I'm going to fix it. So the flare guide is a great way for you to kind of just take control of some of these symptoms and make sure that you're doing everything that you can do. And then, of course, if you want to hit them as hard as you can, ladies and gentlemen, 4.6 stars on Amazon right now. The highest rated book on IC. Hello. Yeah. IC 101 is not just a bladder disease. I was so thrilled. When I checked on it. 4.6 stars. I'm so freaking proud of that. It's great. Chimera says, I found that the people who believed you and then changed their opinion at some point go through that change when our illness becomes inconvenient to them for some reason. That's a really good point. That's a really good point. And I think the most poignant part is that people stop inviting you in the first place. You know, they just do. It's like, well, she can't come anyway. You know, just tell her about it. But, you know, if she's feeling good, she can come. And then all of a sudden you stop getting invitations, or you get a secondhand invitation or a third-hand invitation from somebody else. I mean, that happened to me with a family party just like 2 years ago. Big family party. Somebody called, say, hey, you going? I'm like, what party? Oh, well, it's such and such birthday. First I've heard of it. Well, everybody's coming. Well, first I've heard of it. Clearly I wasn't invited. And then, you know, somebody called me and said, oh, you can come. It's okay. We just forgot you. It's like, oh my God. Admit it. So I think always be the calm port in the storm. You don't have to be defensive. You don't have to feel badly because you're hurt. You're hurt. You're no different than somebody who got hit by a car. And you deserve the same love that they do. And one of the mistakes that I see patients make is they hide the pain. They hide it all from family and friends. Mothers and fathers hide it from their kids. Please don't do that. Because your job is to role model to your kids that when somebody in the family is hurt, you help them. You don't hide it from them. You help them. I mean, you ask for their help. Those children need to learn that one of the blessings of family is that they step in and help each other when people are not feeling well. Right? So it's tricky. And I guess, again, for me, right, this is for me, you know, I have had widespread pain since I was a kid, okay? Literally since junior high. And I've been having a lot of deep thoughts about this recently, the last couple of years. Again, not my fault. I didn't do anything wrong. I was attacked. Okay, so we totally get that. I have come to accept that my job is to create a life that I want to live. That it is never somebody else's responsibility to make me happy, nor should I ever depend on somebody else for my happiness. That it is my job to make my home a safe place for me. It is my job to do things that support my health. It is my job to create the life that I want to live for the rest of my life. And I think that I was really stuck in rescue mode for a long time. And I think a lot of it had to do with the fact that I was not rescued as a child from what happened to me. And my mother apologized for that when I was older. She said we just didn't understand how bad it was. And I just always thought that I would be rescued. And now I know that, yeah, I'm going to be rescued, but I'm the one doing the rescuing. I'm rescuing myself. I'm not going to depend on anybody else. I want to create a calm, comforting home that's perfect for me, not for anybody else, for me. So you have nothing to hide, no shame, no blame at all for anything that you're going through. If you get an invitation and you think it's going to be to a challenging event, you have the right to say no. You also have the right to say yes. You have the right to bring the food that you want to bring. You have the right to bring the medication you want to bring. You have the right to leave early if you need to leave early. Believe me, I did that. I guess the other thing that I started doing is I always drove myself. I didn't normally go with anybody else so that I could leave without inconveniencing other people. And I did that for years. I would usually just kind of, in the middle of an event, just kind of walk out the back door and not tell anybody I was leaving. And I don't even understand why I did that. But I did that a lot back in the day. I don't do that now so much. So anyway, so here, hold on a sec. So hold on a sec. Yeah, you got some good comments here, my friend. Very, very good comments. Alina says, I love this statement. You're going to be in pain regardless. So why not just continue living a normal life like going to work? Oh my God. Yeah. Although I will say, so back in my first year with IC, I had what I call sick all over days, where I just, like 5 days out of the week, the first year or two, I just felt so ill. And I couldn't tell you why I felt ill. I just felt very, very ill. And my sister and my mother were taking the grandkids over to Marine World, and my mom said, well, you can be ill at Marine World. Just come on with us. And I did go with them, feeling ill. And I guess there's two sides to that story. But listen, if I'm ill and I'm going to need the restroom, I'm really not going to. I don't really want to get in a car and go anywhere. I'm certainly not going to go on a long car ride. I'm going to go somewhere where there's a lot of bathrooms. You know, I was a kid. I didn't understand what I understand now. Frey said, they blame us for making excuses and think we're not so bad. Okay, so like, again, for the holidays or for special gatherings, invite them to your house. Do a potluck. Say, hey guys, really love for y'all to come over to my house. Let's just have a party here. That way you're at home. You can make the food that you need. They can bring the food that they want. And yes, it does mean you're going to have to clean your house. And yes, there are some people who are very ill and they cannot clean their house. That's not going to work for them. But if you can, it's okay to invite them to your house. It is. I mean, like there's this temptation to completely self-isolate. You can't do that. Do not self-isolate. There's no reason for you to self-isolate. You've done nothing wrong. You're not a parolee who, just got released from prison. Come on, you're a legitimate person who just got hurt. You absolutely deserve to be included in everything. But you have to make connections too. You've got to call them. You got to call people and say, hi, I'm here. Yeah, it's been a rough couple of years. Yeah, it's been a rough couple of months, but I'm still here and I still want to be friends. And And I just love talking with you, and I hope that we can continue to talk while I'm on this journey. If not, come on over to the house and watch a great movie. Or, have a nice meal. Or play games. Paula is from Michigan. David is from New Jersey. Miriam says, do you tell people all the time or some of the time? Okay, so Miriam, here's the funniest thing. Most of the time I will just blurt it out. It's like, hey man, I work with patients who have pelvic pain, and my specialty is interstitial cystitis bladder pain. So these are patients who are literally getting up and peeing all night long. They might have pain. And you'd be amazed at the number of people who say, oh my God, my aunt has that too. Or, oh my gosh, I have that too. It's like, even if I'm on tech support, like I was working with a guy at a shipping company, and he goes, oh yeah, I was just diagnosed with that. Can you help me? It's like, yeah, definitely. Beth said, I had a similar experience with the whole sleep apnea thing. I think they're targeting anyone over 65. When the nurse practitioner decided to go ahead and get me scheduled for an overnight test because she assumed the take-home test wouldn't be adequate, I canceled it all. I never wake up gasping. I wake up primarily to head to the bathroom, thanks to IC. Yeah, that's exactly what I said too. I mean, my only motivation is just really wanting to prevent AFib. I do not like having AFib. It sucks. Atrial fibrillation. Brandon says, my family thinks I'm nuts because I'm sensitive to a lot. Oh my God, Brandon, thank you. That's a great topic. They don't understand my pain. They make it seem like I'm over dramatic. Exactly. So in this widespread pain phenotype, right? So if you've got multiple pain conditions and anxiety, the other thing, you've got very sensitive skin, wicked sense of smell, sensitivity to light, sensitivity to sound. I remember my first year, UC Berkeley was doing a study on why IC patients had a remarkable sense of smell. Okay, we know why. Because that's part of this central nervous system dysregulation, this injury to the central nervous system. And I can remember, I was attacked in 4th grade. I remember in 6th grade, we used to have in our family room where the TV was these awful hanging lights. And they always irritated my eyes. And so I'd be watching the TV like this, or I'd put a pillow over it. And it's like, please get a dimmer. You need a dimmer in here. I can't stand it. And that was light sensitivity. And the other thing too is the smell sensitivity. I mean, if you've got a wicked sense of smell, as so many of us do, it's freaky how we can smell things that nobody else can smell. I mean, I have found more gas leaks in my neighborhood that PG&E offered me a job. They're like, we don't know how you smell this. I have now found 4 or 5 gas leaks just in my neighborhood alone. The most recent one a couple years ago with gas coming up out of a crack in the street. Fire department was here. Everybody was here. It's like, and they were like, yeah, you're right. This is a gas leak. It's a small one, but it's a legit gas leak. And they had to dig up the whole street, but then the downside is that they don't necessarily understand or respect the fact that we really have this very, very sensitive sense of smell, and smells cause pain. So I remember my dad, before he died, we had a little spill in my garage, and he decided to clean it with turpentine. And so like this 2 foot by 2 foot section of the garage floor was coated in turpentine. And I had happened to treat it with baking soda and vinegar and something else, and it created a really bad chemical reaction. Anyway, he comes walking in here, and it's so the turpentine is wafting off of his body. It's like, he's like, hey, I fixed it. And I'm like, what did you do? And anyway, the fire department came, and paramedics had to assess me because I had such a bad reaction to that smell. So yeah, they don't really get it. And I would just say to my dad, you paid for my first 2 degrees. I mean, granted, I worked a lot, but I've got a degree in chemistry and a degree in pharmacology. He's like, but he would never believe me about chemicals. It's like, I was in the war. I was dealing with turpentine on ship, not a big deal. Mercury, I can handle mercury. I can handle any of that. It's pretty funny. Dolphin said, I had several bladder surgeries due to mesh erosion. People say to me that I look fine. I tried to explain that sections of my bladder were removed. You had to give up your hairstylist career of 38 years. You were approved for SSDI in January. Excellent. Really glad to hear that. Dolphin, I think like literally the best thing you could do in that circumstance is actually tell them to go to YouTube or go to 60 Minutes or go to Frontline and watch the documentary on mesh. That this is literally synthetic mesh that the company literally told the doctors not to put in the human body. They put it in the human body anyway. It's a polypropylene mesh. It's a big scandal. Turns out this polypropylene mesh migrates through tissue. And so if you had it done to repair a prolapse, very good chance that within 6 months of you trying to have sex, your husband might feel a rough, sharp edge in your vagina, which is the mesh coming through the vaginal wall. The mesh can actually go completely through the vaginal wall. We've had patients where the mesh literally severed their urethra into two pieces, and mesh can attach to the bladder and migrate into the bladder. And the problem with mesh is that it's mesh, right? And so, it's like a window screen, lots of little tiny holes that tissue grows into, and it kind of locks it in place. And so removing this mesh is very, very challenging. The other thing that's freaky about this mesh, and if you watch the documentaries, I should find one and play one during one of these meetings. That mesh starts out as basically a white flat mesh that's soft and malleable that they can shape. When they pull it out of the body, it is black and a hard knot, and it is covered with bacteria. So these mesh erosions are heartbreaking because the company was specifically using mesh that the manufacturer said was never meant to be used inside the human body. And that is why there have been millions and millions of dollars paid off to patients. And so I'm very, very sorry, Chimera, Dolphin, that this happened to you, honey. You're not alone by far. Should never have happened in the first place. And the other crazy thing about the mesh is that the people who are doing the documentary, so when the American manufacturer said, we're not selling it to you anymore, you are using it in a way that we do not approve, you are not meant to put this in the human body. And the company is like, okay, we'll get it from China. So then they bought like 20 years of this mesh from China. But guess what? They had to change the labels and hide the labels on the boxes as they were being shipped to China. Because, just completely, fraud. If you got to change the label and hide what you're shipping, then there's a problem here. And even worse, when the filmmakers actually went to China to try to actually find the manufacturer, they were like behind this little dirty storefront. And then when the mesh came here, it didn't meet the same testing standards that the original mesh did. And yet they were still using it. So, it's all about follow the money, honey, in the end. I just think as I'm getting older, so many of our challenges with healthcare are people trying to make a buck, and they don't care if they're harming other people. Yeah, Chimera says kudos to the manufacturer for saying they didn't want to get sued. Also, I'm sure they were probably sued. They might have been. I don't know. This was like 15 years ago. Yeah, no. It's amazing. It's amazing when you actually look at it. I don't remember if the documentary was on Frontline, which is one of my favorite documentary sources, or if it was on 60 Minutes. But just search for mesh documentary and it will give you everything that you need to know. Hold on a second. Here's a question. What have you eaten today so far? I had a smoothie. So my breakfast / lunch was a smoothie this big that was frozen banana, blueberries, strawberries, just a few, not a lot of strawberries because strawberries can be a little bit more acidic, with a protein Greek yogurt and a little bit of beet powder for my heart. I'm also learning that I have to do small portions. I don't eat a lot during the day, but man, after dinner, I tend to eat a lot and then I stretch my stomach out and it's not good. I've got to really focus on small portions. M. Keller says, last week you told us you were drinking lemon juice and water. Is lemon not a trigger food for you? No, because I'm pelvic floor driven, honey. My bladder wall's fine. Despite the fact that I was peeing every 15 minutes and in serious bladder pain, whenever they looked at my bladder, I've always had a perfectly healthy bladder wall. My pain was mostly after urination rather than before urination. And so at least now, again, my bladder is perfectly healthy. It's my muscles that are the problem, although I do have atrophy now. So I am entering atrophy. I use my estrogen to try to reverse some of that. And so I didn't drink lemonade for 25 years. I didn't. Let me tell you, I followed the icy diet like nobody's business. And the only reason I tried it is I had COVID and I was coughing so badly. The only thing I could imagine that would help me was hot lemonade with honey. And so I bought some. This was actually 3 years ago. And I was shocked. I didn't flare, which told me that any residual damage done by ischemia, sorry, my thing keeps falling off, had healed. So any legacy of bladder wall irritation from tight pelvic floor muscles had healed, and I can eat pretty much anything now. Chimera said, no question, they were added to the lawsuits. That said, a lot of companies do calculations that they could make way more money than they would have to pay in settlements. Exactly. I mean, the last estimate I saw said that Elmeron was a $5 billion market. Elmeron, the medication, the only oral approved medication for IC that's now linked to retinal damage and blindness and inflammatory bowel disease and polyposis and colectomy. And yet, it's considered a $5 billion market, according to one website that I recently read. I was shocked. It's crazy. Dolphin said, I had mesh for uterine prolapse. It got infected. It eroded into my bladder, small intestines, tailbone, pelvic bone. I did not have bladder issues prior to my first surgery. Yeah, honey, number one, it eroded into your bladder. And so that's certainly going to trigger some bladder symptoms for sure. And then you've got to deal with the fact that the mesh removal also did its fair share of damage and trauma to those tissues. The good news here is you got it out. Be proud of yourself. You did it. You got it out. The hardest part is over. Now it's about healing. And now it's about making the life that you want that adapts to your needs. So like for me, I have neuralgia across my chest from my breast cancer surgery. I do. I'll probably always have that. So I have to learn to live with that. I just have to adapt. And I'm doing that. I'm not letting it win. Yeah, honey. What kind of bladder damage do you have from the mesh? Can you describe that for us? All right, let me come back to Facebook here. Sherry said, my brothers all right under me have known me to have this condition for many years, but they don't like me complaining and talking about my pain. They believe me, but it's taxing on them over time. I get it. Oh, I know. Sherry, listen, it's your life. If somebody asks how you are, you don't have to hide it. You say, yeah, I'm having a pain day. And Sherry, in your case, you get to say, hey, we certainly understand why a lot of this happened because I had that really bad fall that left scar tissue in my pelvis. Now we understand. Teresa said, I'm sick of doctors minimizing things. I'm scared of the DEA to properly treat things scared of the DEA to properly treat. Next time they want a pelvic exam, I'm going in with Teresa. Okay, Teresa said, next time I have a pelvic exam, I'm going in unshaven because I have IBSD as well as a locked pelvic floor that won't unlock. You've been through all the treatments. So, Teresa, this brings up something really, really interesting. And that is, why is your pelvic floor locked in the first place? Was there an injury? That's like the pivotal question of patients who are going through physical therapy is, are my muscles responding? Are they relaxing and releasing? Or are they staying tight? If they're staying tight, we have to figure out why they're staying tight. Normally, that's a bone problem. Bad hip, bad SI joint, bad tailbone, pubic bone, bad knee. And for many patients, it's bad feet. It's how your foot hits the ground. Well, if your foot is hitting the ground incorrectly, that's going to lead to pelvic floor stress in the long run. Miriam said, I don't know what to do if my bladder hurts. Miriam, if your bladder is hurting, we have to figure out why. And I would encourage you to get our flare guide if you can. Whoops. Get our flare guide. It talks about what causes bladder wall flares and what to do about them. It also talks about what causes pelvic floor flares and what causes urethral flares and what causes rectal flares and what causes hormone flares. Hi, Boria. They get tired of it. It's so hard on them. That's harder on you than them. I just think that you can't. It's kind of the same way with doctors in a way. You can't ask impossible questions that they simply can't answer. And so like with a doctor, if you say, will I ever get better? It's like, tell me I'm going to get better right now. Give me one thing that'll make me better right now. And you're putting the doctor in a very, very difficult spot because in many cases, the doctor still doesn't understand why you're in pain in the first place. We got to do the right diagnostic workup first. Our job is to find the underlying cause of the pain, whether it's the bladder wall or the pelvic floor or nerve or whatever. And kind of the same is true with family. I mean, they're not obligated to care for you, especially if you have a bad relationship with them in the first place. Ideally, they will be there for you just as you would be there for them. Ideally, if that's possible. Veronica says it's as if other people are embarrassed when you speak about bladder pain. I'm not, but they are. Well, that's the gift of getting older. I remember when I was going through my IBS in my 20s, I could barely talk to the doctor about it. I was so embarrassed. Now it's like, hey, could you just look at my rectum? I want to know why it hurts. Larissa said, yes, my husband calls me a bloodhound because of my very sensitive sense of smell. I also have taste too, and I'm from South Carolina, the wonderful state of South Carolina. Borea said, for sure, I don't know how they don't believe it's a very painful experience. Brandon says, are relations taken as seriously as Hunner's lesions? No, they're thrown out as being meaningful. Let me get a picture and I'll show you. So this goes back to the old days of what is interstitial cystitis. So, and we happen to have this new history that was done. Interstitial cystitis was first discussed like in 1805, and then but they called it parenchyma cystitis, something like that. And then the first time they used interstitial cystitis was like in 1870, somewhere in there. And then in the early 1900s, when they had invented a cystoscope, they first saw lesions. So they were thinking bladder pain is a result of a lesion in the bladder. And then somebody saw petechial hemorrhages, little red spots during a cystoscopy, a hydrodistension with cystoscopy, and they thought this was a bladder disease, right? And so really from like, I don't know, maybe 1940 till literally, I don't know, 5 years ago, they thought that these little red dots was actually a disease called interstitial cystitis. So in our first guidelines for IC for research, the guidelines said you can let somebody into an IC study if they have this or if they have Hunner's lesions, which look like this. So look, big bloody wound, right? These are lesions. That's very different from this. These are little red dots. So a doctor years ago, literally back in like 1988, 1989, said, hold on. This is not a disease. This is what happens when you stretch the bladder. And he proved it. He had 50 women scheduled for a tubal ligation. He asked them if he could do a hydrodistension. None of these patients had any bladder symptoms at all. And when he did a hydro and he looked in their bladder, this is what they found. And when you stretch the bladder, you're breaking things. You're causing pinpoint hemorrhages. So our last AUA guidelines finally said, this is not specific to IC. This does not mean that a patient has IC. We now believe this is basically the result of the test itself. Now, other guidelines say they're meaningful, but it's marginal at best. They're not specific to IC. They're specific to the test. Okay, so Brandon, they're not taken seriously anymore. I mean, clearly it shows a bladder that's pretty irritated and inflamed. The question is why? And it's like, that's what happens when you stretch, especially if you overstretch the bladder. If you do what we call a high pressure, long duration hydrodistension, which they did years ago, that back then they thought the more you stretch the bladder, the better. Now we know the more you stretch the bladder, the more damage you do. So hydrodistensions for the last 10 to 15 years have been what we call low pressure, short duration to not cause this as much. And like I said, when I had my hysterectomy and they did a hydrodistension, I had a baby bladder. Like there was nothing wrong with my bladder because he did a very, very low pressure just to look at my bladder, make sure they hadn't punctured it or perforated it with a stitch from a hysterectomy. I love show and tell. I love pictures. They're so great to be able to show you. Laura said, I wanted to let you know I got divorced. You have levator ani syndrome again from the stress. Honey, I'm so sorry. I'm so sorry that you've gone through that. The stress is real. However, as I said before, it is our job to make a life that feels good to us. And sometimes that means parting ways with somebody that might not be treating us well. Or if we have different goals, right? Different expectations. Don't you wish that, like, I totally wish if I could go back to high school, that people could kind of prepare you for marriage a little bit more and say, okay, you've now discovered the opposite sex. You're going to have a lot of boyfriends and girlfriends. Your job now is to find somebody that has the same goals that you have and the same priorities that you have, that you might be able to have a family with. So, for example, if religion is important to you, then you're probably going to be with somebody who has a similar religion. If exercise is important to you, then you're probably going to be with somebody who wants to exercise a lot. Like, my number one thing is exercise. I want to be with an athlete because I am an athlete. Granted, I'm an older athlete, but I'm still an athlete and I still want to go to the gym. So when I'm looking over here, I'm looking at Facebook, and when I'm looking here, I'm looking at YouTube. So Kathy said, I finally got to where I'm feeling better from taking pea leaf and lactoferrin. Yes, but now you're suffering from an old injury. When I fell in 2016, I'm hurting so bad I can't sit. I'm on a heating pad. What can I do to get this under control? I'm sitting on a pad for an injury to the butt. So Kathy, is it an injury to the tailbone or is it an injury to the muscles? We kind of need to know that to figure out what the best response is to that. Like, what was the injury that happened in 2016? Give us a little bit more information. Mary said, I'm about to see my urogyno to discuss this. I need Botox injections. I had somebody call me this week who was asking, she said her doctor wanted to do Botox. And I'm like, okay, so it's very important we know what we're treating. Like, we have phenotypes now. So is Botox going to help a Hunner's lesion? Not so much. Is Botox going to help estrogen atrophy? No. Is Botox going to help chemical irritation to your bladder wall? No. Is Botox going to help widespread pain? No. Is Botox going to help frequency, urgency, overactive bladder? The answer is yes, it could, especially if you have incontinence. This is where Botox can really shine, is with incontinence. And I was just reading, what was I? Here, hold on a second. I'll be right back. I need to go get my magazine that I'm doing a final edit for. Hold on. Our Summer Optimist will be done tomorrow, and we'll be at the printer tomorrow, hopefully. This is our patient magazine. We have a patient magazine that goes to our members. And I just saw this. Okay, hold on a second. 11, 12. So where did I, here, give me a quick sec. I want to find this. Because I just literally. These are monster magazines. It was originally 46 pages long, and it's like, yeah, that's too long. We'll save some articles for our fall one. Okay, is that where it was? So that's the cover. Okay, I swear, where did I just see this Botox thing? It was in a new set of guidelines. Yeah, here it is. So in the new French IC guidelines, so we had new guidelines from the International Society for the Study of Bladder Pain Syndrome, and we had brand new guidelines from the French Association of Urology on IC. And the French Association of Urology guidelines, they broke the phenotypes into bladder-centric, and they put Hunner's lesions in the bladder-centric, which I think is stupid. I think it should be separate. But they've got bladder-centric, widespread pain, allergenic, recurrent UTI, pseudo-infections, and patients who have overactive bladder symptoms. And in this one, these patients may benefit from anticholinergic medications like oxybutynin, tibial nerve stimulation, sacral neuromodulation, and Botox injections into the bladder wall. The thing you just have to remember is that Botox isn't going to fix anything. Okay? It's not going to fix anything. It's a way of managing symptoms. Botox silences nerves, but the nerves always wake up again. So in the end, Botox might give you some residual comfort, and that's not a bad thing, especially if your symptoms are really severe. Not a bad thing at all. But you have to be focused on more than just that. You have to be focused on trying to identify what the underlying cause of my symptoms are and what I can do to address that underlying cause. So we don't want to chase the symptoms. We're going to find the underlying cause and fix the underlying cause. By the way, I got a couple of really exciting phone calls on Friday, including from a new pharmaceutical company that wants to work on new IC treatments. That's very exciting. I can't say who, obviously, but it is what it is. Okay, so Dolphin said, okay, this is important. My surgeon gaslighted me. I finally got to a UCLA student and she saved my life, but unfortunately my bladder is damaged. M. Keller, hold that. We'll come right back to that. Dolphin has pudendal neuralgia from surgical trauma. You have cystitis in your trigone area, sharpshooting pain and urgency. You have a cystocele and we'll need to do repair with that. But you had a cystoscopy a few weeks ago and a suture was still showing in your bladder. You had mesh removed in February. Okay, you had 3 bladder mesh erosions before the full mesh removal. So that suture in your bladder, that's a big deal. Did they take it out? Did they take it out? We got to get that suture out of your bladder, ideally. Thank you, Sandy. All right, let's go to M. Keller. A nurse practitioner told me I had IC. If the doctor did a cystoscopy, said there was inflammation on the bladder walls, told me it's not normal to get IC around the age of 50. Can IC start around the age of 50? It starts in a bunch of women around the age of 50 because it's actually not IC. It's genitourinary syndrome of menopause. You're losing estrogen. And because you've lost estrogen, you're experiencing estrogen atrophy on your vulva, in your vagina, in your urethra, and in your bladder. And that is going to make your bladder wall more sensitive and vulnerable. So it's absolutely common for a subset of women to develop urinary symptoms and IC when they get a little bit older. But same thing happens after total hysterectomy. If you're on Lupron for endo, if you're on estrogen suppression medications for cancer, the bladder needs estrogen to make mucus. that nice thick coating of mucus that protects the tissue. You know, your bladder's like your mouth. It's a hollow organ that's wet and slippery on the inside. And the purpose of that moisture is to act as a barrier. It's thick, it's robust, it keeps urine off of the more fragile cells, right? But the problem with mucus is that it's estrogen dependent. So what that means is that when you're young and you have a lot of estrogen, your bladder can make a lot of mucus. But if as you get older, you just don't have as much estrogen, then your bladder just cannot make as much mucus. So your bladder's ability to defend itself is now greatly compromised. So that cup of coffee you had every day in your 30s and 40s, guess what? There's going to come a point in time where you might not be able to have that in your 50s without having pain, simply because your bladder lacks the ability to defend itself like it used to. And therapeutically, this is called genitourinary syndrome of menopause, and the correct therapy starts with estrogen, that when you give the skin estrogen, it starts to make mucus again. The most natural thing you can do is give the skin estrogen to make your own natural mucus. And remember, the black box warnings were just taken off in June. We can talk about that if anybody has any questions. All right, let me come back here. Miriam says, can you tell if a hydrodistension did damage? Dr. Moldwin did mine, didn't show anything. I'm sure that if you know it's been damaged if they send you home with a catheter. If they didn't send you home with a catheter, then you're fine. Mary said, pre-leaf does nothing for me. All pre-leaf does is reduce the acid in your urine to make it less irritating to your bladder wall. Pre-leaf is not an IC treatment. Pre-leaf just makes food more tolerable. Botox helps, good. So Botox is helping because it's silencing those nerves. So that tells us that the nerves in your bladder wall are the problem. Now we have to figure out why those nerves are so provoked. Are they provoked because you're in atrophy, or are they provoked because you have a nerve injury? And she says she has stress incontinence. You had 4 vaginal repair surgeries due to faulty mesh that eroded. Yeah, you too, honey. And you have overactive bladder. Okay. Oh, the journeys we have shared, right? What a life. Dolphin says, surgeons have no problem implanting the mesh, but they do not know how to remove it once the erosions start. You can see the mesh eroding into your organs until they open you up. It's bad stuff. Yeah, it's brutal. And Dolphin says the swelling you have in your trigone area looks like finger indentations. Weird. You could, honey, if you have them, take a picture of them and text them to me. Or email them to me. I'd love to see them. I have seen hundreds and hundreds and hundreds of pictures. M. Keller said, thank you so much. I appreciate all you're doing for the IC network. You're welcome, honey. You are welcome. All right. So, summertime is when we bring out the nerd. Because generally in our summer issue of our magazine, we're covering all the new IC research that was presented at the American Urology Association meeting in the spring. This year, there really wasn't anything that exciting there, I thought. And so I went with talking about all of the new guidelines that have come out. There is remember last week we did all the confusable conditions that need to be ruled out before you are formally diagnosed with interstitial cystitis. If you can watch that meeting if you're doubting your diagnosis, or again, more importantly, if you're not responding to typical therapy, this is, again, we want to take a step back and revisit this and ask, gee, I wonder if they could have missed something. Believe me, they miss a lot. Why? Because doctors just don't have as much time that they used to actually do a proper diagnostic workup and a proper history. And I think one of the most important things you have to say to your doctor is your history of injury and trauma. Because I can't even begin to tell you how many times we find a history of injury in typical IC patients. We do. Falls, difficult. I was working with a patient this week who had a stage 4 tear from a childbirth. Her symptoms began immediately after that childbirth. Diagnosed with interstitial cystitis. She's a surgical injury patient. She's not a bladder disease patient. Dolphin said she did not take the suture out. She's sending me in for a pelvic ultrasound and kidney ultrasound. I'm concerned about the suture. I do not want a bladder stone from the suture. I would agree with you, hun. But maybe she's, maybe she needs to know what that suture is holding together first, right? They don't want to take something out prematurely. We want to make sure all the tissue is healed correctly. So I think she's being cautious, appropriately so. So doing the ultrasound, maybe even doing a CAT scan, not a bad idea. Not a bad idea, because for all we know, maybe there are a few other sutures in the nearby area that could also be triggering some of your symptoms. So I like that. To the IC patient who was here 2 weeks ago, who shared that she went back to Brazil because she wasn't getting the care that she needed here in the United States. I have an editorial. When the world's most expensive healthcare system stopped seeing the patient. I told her story. It's in the magazine. On the IC Network website and in our magazine, we have Could It Be Something Else? A Guide to Conditions that Mimic IC. And in these conditions, in this, it's broken up into urological, gynecological, bowel, etc. In the urological confusable diseases, we're dealing with bacterial infection, fungal infection, tuberculosis, cancer, inflammatory cystitis from ketamine, radiation, etc., overactive bladder, an obstruction, and a foreign body in the bladder from previous surgeries. Hello, there you go. There you go. Okay, what else do I have going on in here? We have the French guidelines, and I'm not going to say France is a hot potato of IC research or a hot spot of IC research, but their guidelines are good. Their guidelines are very, very good, and guidelines are important, so all the patients are treated correctly. And in here, this is their protocol. So the patient goes to the doctor with bladder pain, pressure, discomfort greater than 3 months. The doctor is supposed to take a history and maybe give you some questionnaires that will measure your how often you're going to the bathroom and your pain levels. Then the doctor is supposed to do a physical examination to check the pelvic floor, vaginally and rectally, suprapubic palpation, urethral and vaginal tenderness, and a neurological exam. When they do that, then they might consider doing some imaging, like an ultrasound, to check to see if your bladder's emptying itself, because that's important. Because if your bladder's not emptying yourself, we want to consider an obstruction. Maybe we're dealing with something that is obstructing the flow of urine. The next step in Europe is a cystoscopy and a hydrodistension, so that they can, if there are Hunner's lesions, they can treat them, and to measure bladder capacity. Then once they've done that, they do the formal phenotyping, figure out what phenotype you're in, and then they create a personalized treatment plan. In the United States, we don't do the cystoscopy unless the diagnosis is in doubt. So we do the same thing, but this gets done later. unless you got really severe symptoms, a lot of blood in your urine, where we really need to look. In the United States, our health insurance aren't going to pay for cystoscopies and like they do in Europe. So it just is what it is. Okay. So that's interesting. All right. We have another new research study on Elmeron's toxic effects on the eyes and the bowel. A new retrospective case series from the UCLA Stein Institute reveals deeply concerning results about the toxic effects of Pentosan to the eyes and bowels. And the bowel findings in particular were more alarming than the eye findings. In this latest study, 8 patients were tracked over a 6-year period after exposure to Elmeron. Participants had used the medication for a median of 25 years, with a cumulative exposure ranging from 45 to 4,672 grams. Severe polyposis was found in 6 out of 8 patients. So what is polyposis? Polyposis is the uncontrolled growth of polyps in the bowel. It becomes a veritable carpet of polyps, hundreds of polyps. And there are different types of polyps that can happen. There are polyps that look like mushrooms that have kind of a stem. And then there are polyps that are flat. And the flat polyps are the ones that are most notorious for turning into cancer. And the flat polyps are what we often see with carpet polyps. And in some patients, the polyps get so big they can block the bowel, and in others, they're just very long and they affect large sections of the bowel. So polyposis can progress to inflammatory disease, abnormal cell growth, with a corresponding increase of cancer, bowel obstruction, bleeding, and anemia. This is not the first paper to document changes in the bowel. 3 prior studies have also documented GI changes in patients using the med. Notably, patient number 3 in the UCLA study had the lowest exposure at just 45 grams via a subcutaneous injection of the medication for arthritis, yet he still developed moderate retinal damage and microscopic colitis. Another recent study identified the first reported case of pigmentary maculopathy in a patient who received Pentosan through a bladder installations with a cumulative dosage of just 5 grams, 5.8 grams. This suggests that the risk of toxicity is not limited to patients with decades of high dose use. And they also found that the eye damage progressed over time. At the start of that study, 5 eyes showed retinal atrophy. At the end of that study, 12 eyes showed atrophy. So we go through that. And we have a big article on the concept of chemical injury. And I was having a conversation with an IC researcher on Friday. We were just like really talking about the foundation of this. And we are both of the opinion that today's modern day diet is from the 50s on, creates a foundation of trauma to the urinary tract, because manufactured foods are just in some cases so incredibly toxic to our body and toxic to the tissue. You have to remember that our bodies were designed for life 1,000,000 years ago. We didn't have energy drinks 1,000,000 years ago. We didn't have soda 1,000,000 years ago. We didn't have caffeine 1,000,000 years ago. And so we have to ask ourselves, how can our bladder defend itself? How would it normally defend itself from just normal urine? And again, 100,000 years ago, urine was basically water combined with, what were they eating 100,000 years ago? They were eating anything they could catch, real food, or maybe a little bit of fruit or berries when they were ripe. That's it. That's it. That's what our bladder was designed for. And so you look at what we have been putting our body through for the last 50 years, and it is just devastating. This massively high amounts of acid every single day from soda. Then throw in the inflammation that the sugar causes. And throw in the damage that artificial sweeteners cause, and the preservatives and the chemicals in our food and all that sort of stuff. So is it possible? And I make this argument, and I've made this argument for years, that for many of us with bladder-centric symptoms, that this is not a disease at all, that this is cumulative injury to the tissue. And he completely agreed with me. Completely agreed with me. And I think what's challenging here is that when you have the symptoms of frequency, urgency, pressure, pain, you're going infection, infection, infection. That's like, no, it might not be infection, infection, infection. It might be injury, 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 because you have a horrific diet. And so what are the chemicals which are going to injure the bladder? Well, the acids, citric acid found in citrus drinks and soda, ascorbic acid found in vitamin C, acetic acid found in vinegar. Acids are undeniably painful in quantity. We're going to look at medications like chemotherapy. Those are going to injure the bladder. We're going to look at some medications, such as a potassium product or a high vitamin C product. That has the potential of injuring the bladder. Artificial sweeteners, we know, can injure the bladder because they're metabolized into aspartame, specifically into formic acid and formaldehyde. We have a new case of a gentleman, 77-year-old man from China, who started a Chinese herb called Campo. 35 days later, had all the symptoms of IC, and it was actually the herb that was causing the problem. When you stop it, the bladder heals and symptoms get better. Alcohol. I mean, listen. We are a society that loves to party. We are a society that celebrates wine as a big part of family meals or beer after work. And it is an undeniable fact that alcohol destroys tissue. It's destructive. And so, do we have any data that suggests that alcohol could be eroding the bladder wall? It's a good question. Sodium, potassium, high levels of sodium, high levels of potassium. So all those super, super salty foods, there's a consequence to that. There's a big consequence to eating high amounts of salt. Salts are an ion. They trigger nerves. Salts can cause your body to, I want to make sure I get this right. Well, number one, high blood pressure. And that's because when you've got a lot of salt in your bloodstream, your body pulls in a lot of water to help modulate the salt. And then you end up peeing more. But so it's a thing. Chemical injury is a thing. And we're going to see a lot more about this in the future, I believe. We have our international guidelines for IC. They're a little, they're really academic. They're not really for patients. I mean, in terms of their justification for their phenotyping. We have an article on what doctors often miss about men with IC, specifically the prostatitis pipeline, that if a gentleman goes to the doctor with frequency, urgency, pressure, pain, the odds are it's going to be assumed that they have a prostate infection. They're going to probably be put on antibiotics, intensive antibiotics, long-term antibiotics. If those don't work, then they're probably going to put them on prostate meds. If those don't work, then they eventually get the IC diagnosis, but in some cases, it takes years for them to get the correct diagnosis. I understand too, the great majority of men have pelvic floor muscle injuries. It's not their bladder at all. It's all the football they played, all the motorcycles they were riding, and traumas. Here's something new. This is very, very interesting. You know, we certainly have a group of patients who get recurring infections. And the question is why? Why do patients end up getting, a small subset of patients do legitimately have infections every month confirmed by a culture. So the underlying rationale is number one, there might be an atrophy, and basically if you're in atrophy, the bacteria just swim up to the bladder wall cells and infect them because there's not enough mucus to protect them, to push the bacteria away from the cell. So estrogen atrophy is a big cause of recurring infection. The second thing we're going to do is we're going to look at immune dysfunction. Some patients have a weakened immune system that makes them vulnerable to lots of different types of infections, from sinus infections to bladder infections, etc. But did you know that fatty liver disease is now also being implicated in recurring infections? I didn't know this. And so we had a patient call the IC network, and she was having recurring infections, and then they ended up doing a sonogram for something, and they found that she had significant fatty liver disease. So let me read this to you. And she hadn't drunk alcohol in 40 years. An IC patient called our office to share what she believes is causing her recurring infections, non-alcoholic fatty liver disease. There is growing evidence that fatty liver disease is associated with a higher risk of recurring UTIs, although fatty liver itself does not directly cause bladder infections. But here's how they would be connected. People with fatty liver disease also have insulin resistance, type 2 diabetes, or prediabetes, obesity, or metabolic syndrome. Each of these conditions independently increases the risk of UTIs because they impair immune function, increase glucose in urine, promoting bacterial growth, as well as altering the urinary and vaginal biome. Fatty liver is associated with chronic low-grade inflammation throughout the body, which can increase susceptibility to recurring infections. And a new area of study is the gut-liver-bladder axis. Patients with fatty liver disease often have changes in their gut microbiome. Since many UTIs are caused by bacteria such as E. coli that originate in the intestines, alterations in the gut microbiome may increase the likelihood of recurring UTIs. Anyway, so for people with IC, recurring UTIs complicate the diagnosis, yada, yada, yada. You can read this in the magazine when it comes out. But it's worth evaluating if your blood glucose is out of whack, if your bladder's emptying completely, if what your vaginal health is after menopause, and what your kidney function is. What do we do to reduce the risk? You got to achieve and maintain a healthy weight, improve your blood sugar control, get regular physical activity, eat a diet rich in vegetables, fiber, and healthy fats while limiting refined sugars, staying well hydrated, and a prompt treatment for UTI. Oh, I kind of think that, again, given the fact that our today's manufactured fast foods are just so unhealthy, I think a bunch of us have non-alcoholic fatty liver disease. Okay, time for a pee break. I got to go to the bathroom. Give me 30 seconds. Anybody needs to go. And when you come back, I need you to rate your ability to urinate. Does it take time? Did you have to wait several seconds before you can release, or could you release on command? I'll be right back. All right. I gotta say that was poor for me. Took me about 5 seconds before I could release. Jill is not peeing like a horse today. That means my muscles are tight. All right, hold on a sec. Darla said, I've had 2 urologists recommend Elmeron within the last 6 months. What'd you say to them, Darla? It's like, hello, I want to protect my eyes. I mean, I'm shocked. Mary said, I'm a diabetic and must use artificial sweeteners. I try not to use them too much, but you can't have sugar. I get it. I get it. And I have an article in here, just so you know, in our magazine, Mary. Yikes, artificial sweeteners linked to memory and cognitive decline. This is our Consumer Alert article in the magazine, and this was a new study. Followed 13,000 adults and examined 7 sweeteners that contain little to no calories, including aspartame, saccharin, acesulfame K, erythritol, xylitol, sorbitol, and tagatose. These ingredients are frequently, they're added to water, soft drinks, etc. They tracked their brain health for 8 years. And again, it was 12,772 patients. People who had the lowest consumption averaged 20 milligrams per day, while those in the highest group had 191 milligrams a day, equivalent of 1 diet soda, like 1 aspartame diet soda. Okay. Let's see. People who consumed the greatest amount of sweeteners experienced a 62% faster decline in overall thinking and memory abilities than those who consumed the least. Researchers estimated that this difference was comparable to about 1.6 years of aging. And it was let's see, age mattered. Among participants younger than 60, those who consumed the most sweeteners experienced the fastest declines in verbal fluency and overall cognition than those who consumed the least. And researchers did not find that same association in people over the age of 60. And it was linked to all of the sweeteners. Tagatose was the only sweetener that was not linked to cognitive decline. So the message here is, number one, this is a huge, robust study of 13,000 patients over 8 years. We cannot throw this out as a bad study at all. And number two, try to use it as least as you can, hon. All right, here, hold on a sec. We have an article on the boom and bust cycle of flares. In other words, you have a great day, you're feeling wonderful, so you go for it and do everything that IC held you back from doing, and then bam, you get a flare. So disappointing, so predictable, and we explain why. And I wrote an article on Greek food, because Greek food is wonderful food and very gentle on the bladder, for sure. Now, I also want to show you something I found that might be interesting. Oh, Joanne says she's going to bring the PA, the flare book, and you're going to order a few more. That's great, because that's how we get the word out. And, I sent my flare book to Harvard, or to a doctor who practiced at Harvard, and she got back to me and said it was wonderful. that we don't have anything like this. The goal is to give you the tools and resources so that you can nip these flares in the bud, right? Now, I want to show you something else I found. This is so interesting. Reflex Gourmet. Now, there is a chef over in the Napa Valley who was struggling with really bad stomach problems. And a lot of IC patients, we have the same thing. I suffer from gastroparesis, so I tend to get a lot of gas in my stomach. And the more gas in my stomach, the more it makes my heart all weird because it's a whole vagus nerve thing. And so I tend to use Gaviscon, which is a medication that kind of puts a foam at the top of the stomach so it doesn't go up and start irritating things. I don't have GERD at all. Mine is a vagus nerve sensitivity that affects my heart. Okay. So, but the challenge is, it's magnesium and calcium, and I'll suck on 1 or 2 of those a day, usually after a meal, and I'm not comfortable with that. So I found this company called Reflex Gourmet, and it is a formula created from seaweed that acts to coat the stomach. So it does the same thing that Gaviscon does, but from a natural source. And what it has in it is alginate complex, which has a little bit of a calcium, sodium bicarbonate, and sodium alginate, which is from algae. And then it just has GI water in it and natural flavoring, a little grapefruit seed extract. So here it is. I got the vanilla caramel rescue flavor. And it's amazing. So look at that. It looks just like caramel, right? It tastes just like caramel. Oh my God. It's like so freaking good. And it's good for your stomach. So what it does, they're not paying me, guys. Just understand. I just found this. I got this like 10 days ago. Is it puts a layer of like foam on the top of your stomach contents to stop those from going up into your esophagus and causing GERD. And there are a bunch of interesting flavors, but it's such an interesting story. So Reflex Gourmet, they're based in Napa, California. So I have started incorporating this into my daily routine. And I'm going to say it's not quite as good as Gaviscon, but it's close. So I am excited about this, to have something totally natural that will help with GERD or gas in your stomach or stomach irritation. Pretty exciting. Reflex Gourmet. You might want to check them out. All right, let me come back to Facebook here. Mary has, let's see, hold on a sec. Debbie says, I have a kidney disease and I pee out my electrolytes. I can't do anything about it. Which of your meds might help it heal? I don't know, hun. If you're asking for something that will reverse the kidney disease, that's not my area of expertise. I wish I unless I'm misinterpreting your question. I might be misinterpreting your question. So ask it again in a different way. David said, I was diagnosed with chronic prostatitis and Hunner's lesions at the same time. Yeah, that's interesting. The Hunner's lesions are the most important part. And so at least they looked in your bladder. A lot of doctors don't even go up and look at the bladder. They just focus on the prostate. Mary said, I have an Axonics Neurostim device for both fecal and bladder incontinence. I've had it for 5 years, but it has stopped working. One reason I'm seeing my urogyn at the moment, I'm again losing urine a lot, having to use the pad. So they might need to replace the Axonics device if that was really working for you. Mary, this is where neuromodulation shines, and that is with the treatment of incontinence. And so, especially fecal incontinence. So, it's not surprising that a device might malfunction, might shut off, might just become a little bit less effective because sometimes leads move, and things happen and things disconnect and break. So I'm excited that it worked for you for your incontinence, and it's going to be very interesting to see what your urologist wants to do. Anne says, my muscles are tight too, nocturia at night. What can I take? And physical therapy. There's no medication that you can take other than a muscle relaxant. You can take baclofen or Flexeril, but in the end, we have to work on the muscles. We got to get the muscles healthy. That's physical therapy. Sherry said she had to push to get pee out, then you barely peed. Yeah, okay. Mary said, you're doing a urination log now. You're up to every 40 minutes. Okay, that's better. Mary says, I kid you not, I'm having memory issues, getting a head scan and MRI in September. Grown. Okay, so there you go, artificial sweeteners. Darla said, absolutely not. She said she's been prescribing it for years with no issues. She was rude. I was just as rude. The other doctor dismissed me. It's just absolutely reckless. Lori says, can I put up their website? Yeah, it's, I think it is, hold on. Pretty sure that's their website right there. Reflex Gourmet. Here, I'll put it on YouTube too. Sandy said, try stevia. The World Health Organization basically said we shouldn't use any artificial sweeteners at all. The only exception they made was sugar alcohols, but like literally a month later, sugar alcohols were linked to increased stroke risk, if I remember correctly. I think that was from Cleveland Clinic. Sherry said, I like your opinion on the use of saw palmetto and cold pressed pumpkin seed to help with IC. This is for my husband, and he is taking Pure and Bladder Builder. There is very good research with pumpkin seed oil, for sure. And saw palmetto, I think, is designed to help urination with benign prostatic hyperplasia. I think, let me look it up. It's not a treatment for IC per se. It's never been mentioned in any guidelines. Yeah, it's for an enlarged prostate. However, rigorous scientific studies show it is not likely to help. It is likely not helpful for prostate issues, though early research says it may offer mild benefits for hair growth. Can cause stomach upset, diarrhea, dizziness, headache. May interact with blood thinners. You should talk with a doctor before use, especially if you're tracking prostate health and other meds. So I don't know. I think the saw palmetto would be kind of a pass for me, but the pumpkin seed, I was at the first AUA conference where the very first pumpkin seed research was presented. There's no research with interstitial cystitis, if I remember correctly. Let me look it up. Yeah, there's no formal scientific research that shows that it can be helpful. but it's and again, I'm talking interstitial cystitis, not prostatitis. The prostatitis research is better, if I remember correctly. I don't know. I don't see much of an issue with the pumpkin. I mean, if you want to try it, I'd say why the hell not? I mean, I eat pumpkin every day. If I could, I would eat pumpkin every day. I love pumpkin and pumpkin seed. So yeah. Mary says, buy sweets. Oh my God, my doctor stopped prescribing Elmeron 11 years ago. Exactly. And Mary says, stevia is nasty. It can be. Stevia can be, you guys, you just got to remember the fundamental problem with artificial sweeteners is that it fakes out your brain in a really, really bad way. So normally when you put something sweet in your mouth, a message is sent to your brain, ooh, energy incoming, energy incoming. Sugar is a sign that we can now use our muscles effectively and just be more active and do what we need to do. Carbohydrates, right? But the problem with an artificial sweetener is that, number one, they're massively more sweet than sugar. So they send very strong messages to the brain. Energy's on the way. But it's a fake out. There's no energy coming because it's not real. It's artificial. And so, about an hour later, half an hour later, the brain goes, hey, man, where's my energy? You promised me energy. You put something very sweet in your mouth. I want my energy. Give it to me now. And because the energy hasn't arrived, your brain goes, okay, we're going to get our energy from somewhere else. So where do we get it? Snacking. So people who use artificial sweeteners snack a lot. And that is, in fact, why artificial sugars is linked to obesity. You think you're doing a good thing, you're not. Sorry, my throat is dry. That's what happens when you talk for a living. My tonsil's going. Hold on, I'm going to cough. I get a little pinprick in my right tonsil. And when that happens, bam, the coughing starts. Okay, we good? I think we're good. Okay. Where was I? You're welcome, Sherry. Sherry says, thank you. That is helpful. A bunch of new research landed in my mail this morning. Let's take a look at that real quick. Okay. Serum 17 beta estradiol concentrations in women with IC. A retrospective observational study. Let's take a look at this. This might be interesting. Okay, this is a study from Bucharest, Romania. University there and the National Institute of Mother and Child Health. All right. Hold on a sec. The relationship between circulating estrogen concentrations and IC remains incompletely understood. The study aimed to characterize baseline distribution of estradiol concentrations of women diagnosed with IC. A total of 195 women were included in the study. Serum estradiol concentrations ranged from 3.1 to 712.7 with a median of 40.2. Overall, 109 patients, 56% had serum estradiol concentrations below 50 milliliters. 22% were between 51 and 100. 15 were between 100 and 200. And 13 were above 200. Low serum estradiol concentrations were frequently observed in this cohort of women. Although these findings are consistent with the hypothesis that endocrine factors may contribute to disease heterogeneity, retrospective observational design and absence of a healthy control group preclude conclusions. Okay, guys, like seriously, can we just introduce the concept of estrogen atrophy? Of course, a bunch of patients have low estrogen levels. That's genitourinary syndrome of menopause, which is often misdiagnosed with IC. Okay, so interesting study, but totally, it makes total sense. Like, okay, we would know this. We would guesstimate that, but it's interesting that they confirmed that. Okay, here's the next one. Diagnostic model development for IC and its subtypes. Yeah, that's too advanced for this. Very, very academic. Talks about tumor necrosis factor levels. Okay, so I'm going to have to look at that separately. And here's another one. Okay, so not a lot happening with the research, but that's okay. We're good. We got a lot of stuff happening right now. Okay, so we've been going for 2 hours so far. I am happy to take any and all questions that you have, but you got to give me questions. Once we're done, we're done. And you guys, yeah, and not to be weird, but y'all know I had a double mastectomy. So this is one of my old sundresses. They're missing something. You got to find humor. You got to find humor in breast cancer. That's for sure. All right. So give me questions. Joanne said I missed another note to look up. Okay, Joanne, hold on. Let me see if I can find it. And you guys, if I miss a question, just ask it again. Remember, I miss stuff, especially on Facebook. I'm looking. I see M. Keller. I see Dolphin. I see Chimera. M. Keller, Dolphin. A nurse practitioner. Okay, that's M. Keller. Joanne, I don't. Oh, you're going to bring it to your PA, the IC Flare book, and you're going to order some more. Yeah, I saw that. I don't see another message from you, honey. Is there another one? Am I just blind? Possible. So if it was another one, ask it again. Mary says, could I have been born with IC? Mary, we have phenotypes now. Okay, hold on. Wait a second. Joanne, I just don't see it, honey. I'm sorry. All I see is just ask it again. Just cut and paste it and ask it again, honey, because I'm sorry. I just don't see it. Okay, so Mary's question, can I have been born with IC? Well, Mary, we have to consider the concept of phenotypes because remember, IC isn't just one bladder disease. That's wrong. IC is a pelvic pain syndrome for which there are many potential causes. And our job is to try to find underlying causation. So, concept number one, or phenotype number one, Hunner's lesions. Hunner's lesions have been connected to viral infections and neuroinflammation and posterior fornix syndrome. Are those inherited? Well, you could potentially get a virus from a mother, but I don't see that hard coded in DNA, but they always want to, before childbirth, they want to know if that mother has herpes or anything like that. They have to take special care. And so, but again, that's not a genetic connection. That's just exposure during childbirth. Is chemical injury inherited? No. Is estrogen atrophy inherited? No. Could you have inherited another condition which might have limited your estrogen levels? Maybe. Is pelvic floor dysfunction inherited? No. But if you inherited, say, a club foot, if you got some sort of genetic abnormality and have, for example, club feet, that could have caused pelvic floor dysfunction, which then could cause pelvic pain and IC. Is widespread pain inherited? Generally, it is driven by trauma. So what I have seen, and so just to kind of give you context here, I have seen like multiple children in the same generation have IC and or IBS and or migraines and or fibro. And so I will have patients call when we're going through their phenotyping and their widespread pain, and they usually volunteer, yeah, my sister has that, my brother is that. We all have something wrong with us. And I'm speaking specifically about a patient who called not long ago. And it turned out that they had all grown up with a very abusive parent. And they were all in extreme levels of fight or flight because they endured abuse for many, many years from a violent parent. And so that's not typically inherited, but that is a common experience that multiple family members can go through, which could create the foundation for widespread pain and IC. I hope that makes sense. David, did I say Hunner's lesions hereditary? Not that I know of, honey. Marlena says, my doctor switched me from estradiol to Intrarosa. Any advice? Well, you just have to see how you do. I mean, there are just kind of different fads and different options. And is that a bad thing? I don't know. Lots of people use Intrarosa and lots of people use estradiol. I think you're just going to have to give it a try and see how you feel, maybe. What was the motivation? Did the doctor tell you why they were making that change? Debbie said, I'm the one with Gittleman's and I pee out potassium and magnesium. I assume it irritates my bladder. Which of your supplements would you recommend? Well, gosh, what a great question. Pre-leaf reduces acid, but potassium is an acid. Potassium is an ion that's just neuroprovocative. Gosh, what a great question. I think the only thing I can think of is if you gave your bladder wall a little bit more protection with a chondroitin supplement like Bladder Builder or Bladder Rest or Cystomend or Cystoprotect, that might protect the tissue a little bit more. That would be my guess. Arlene says, I'm on a strict IC diet, but I also react to high oxalate foods that are on the diet, like cashews and almonds. Thanks for mentioning that. Yeah, some patients are very, very sensitive to oxalate. So, and in fact, it was, just to give you a little history here. Let's see if I have it. Oh, I do. Okay, hold on. So the very first book that was ever released about the IC diet is this book, A Taste of the Good Life, a cookbook for an IC diet. And it's out of print now. You can't get it now. But the author actually is a very, very good friend of mine. And she wrote a massive amount of information on our website on the diet. So you can get most of the information right on our website. Anyway, Beverly Lauman, who was the Orange County IC support group leader when I was the Northern California Orange IC support. We were both ICA support group leaders at the time. Anyway, she is the first one who brought up oxalates, and specifically, she qualified her recipes as low oxalate or high oxalate, which was brilliant at the time. So recipes with a check mark in this book. So like this one, asparagus roll appetizers. I tried to get her to re-release the book because it's just so freaking good, I mean, it's good. And I think I have 3 copies of it. If you can find that book somewhere, I mean, it might cost you $75 or $80. There are people who find old books. Hold on a sec. Let's just see if anybody is. Sometimes it ends up on eBay. A Taste of the Good Life. Bev Lauman. Let's see if anybody's selling it. It was on Amazon, half price books, Goodwill books. I should just buy a bunch of these. Wow, look at this. Here's one for $7 on Thrift Books. Okay, so you have to search for A Taste of the Good Life, Bev. And it is at half price books for $15.49. It's at Goodwill Books for $8.25. Abe Books for $6.28, or if you want it new, it's $81. And they have 2 new copies from $81. Wow. Yikes. Oh, they also have our IC Chef cookbook, and oh wow, they have a bunch of stuff. Oh, I think that my books are going to end up at Goodwill eventually. Heartbreaking. I am working on our new pain guide right now. So we're working on the pain guide, and I don't know. Maybe that'll be done by the end of this month. That'll be good. We need it. Lori says, you think the pepper that's added to turmeric will irritate the bladder? Oh, I think if you got Hunner's lesions, it might, but for most other patients, probably not. But you won't know until you try it. Lisa says, I'm sorry I was late jumping on today. I wondered if y'all discuss a link between Elmeron and your eyes and colon. I had a total colectomy in 2016. I've been in trouble with my eyes for years now. I've lost sight in my right eye. I did take Elmeron for 16 years. Yes, and in fact, honey, there is. We're the patient group that's leading that charge. We're working with the Emory Eye Institute right now on a new patient registry. Understand that we really did not understand the role in the bowel until literally 2 years ago, and it was. So let me just give you just a tiny bit of history here, and hold on a sec. Let me just grab this article. Virtually in every magazine, we have new articles. Research that's coming out is just astonishing. All right, where did it go? Where did it go? What page is it on? Page 18. Okay, hold on. I got to find page 18. There it is. Okay. So let me give you, Lisa, I want to give you a little bit of context here. So I was an IC support group leader in 1996 when it was FDA approved. I have read virtually every IC patient education material made on Elmeron. In fact, I was hired by Alza Pharmaceuticals to edit theirs years ago, back in the 1990s. At no point did I ever see any mention of eye issues, ever. And I saved them all. I still have some of them. And then the Emory Eye Institute, like 5-6 years ago, I remember it was over Labor Day, and I was sitting right here at this desk, going through the National Library of Medicine, looking for articles that I could put in our magazine, looking at the latest research. And I saw this reference to this letter to the editor about eye issues. And it turned out it was written by a guy named Dr. Neeraj Jain from the Emory Eye Institute. And basically what they said is that we believe that we have found a new eye disease associated with the use of Elmeron, also known as pentosan polysulfate. And they had presented a case series of 6 patients where they had scans of their eyes, and they had published that in the Journal of Ophthalmology the previous spring. But of course, urologists don't read the journals of ophthalmology. They don't have time. They barely read the Journal of Urology. So these guys wrote a letter to the editor of the Journal of Urology to raise this question. Well, I read it, and I was just stunned. Like, what? Like, no way. No way. There's like, how could that be possible that a bladder medication was connected to eye damage? And I went and I bought the Journal of Ophthalmology article. We got a whole giant binder of everything because I was subpoenaed in the federal lawsuits, and I was an expert witness in the federal lawsuit. So as I sat here at this desk, I just burst into tears because I'm like, oh my God, hundreds of thousands of patients have taken this medication. If this is real, this is horrific. And specifically in that letter to the editor, they were very, very concerned that the damage could progress after patients stopped using the medication. So, I just thought, man, let's credibility check this. I had access to 30,000 patients. I'm like, I'm going to do a survey. But what I did is I created the survey, but I first sent it to the top doctors in the United States. And I said, okay, y'all know about this? Does anybody have any comments about this new connection between Elmeron and eye issues? And all the doctors but one said never heard of it. And the one who knew about it had just heard about it. And so I sent him the survey and I said, listen, we can credibility check this right away. So I sent him my survey. He tweaked it, sent it back to me, and then we sent it out. So y'all heard about it because I made the decision to go public with it. My attorney told me not to. My attorney said, sit on this for a year, because I understood the consequences of this. This was going to change the IC movement forever. And I just, in my brain, I was just like, I couldn't sit on it for a year and look you in the eye and say, have a patient say to me, you mean you knew about this for a year and you didn't tell us about it? And so I went for it. I went for the story. And I sent out a blast email to our entire members. The first phone call I got back was 20 minutes later from a woman crying, going, oh my God, you just explained why I'm going blind. I had no idea. Second phone call I got was from a young woman who had taken Elmeron during her pregnancy, and her child was born with problems with his eyes. And she was sobbing, going, did this damage my child's eyes? And I said, I don't know. The survey results were amazing, because I think I had 600 patients respond in our survey, and 54%, more than half, had been diagnosed with retinal disease and had visible changes in their eyesight and in their retinas. That study is still going on. We have 2,500 patients in that study now, and it's now 57%. What was important about our study is we asked about timeline. And because the assumption was the more you took, the longer you took it, the greater the risk of changes in the eye. What we now know is that some patients' eyes change in the very first year. And if you look at the black box warning, instead of saying 15 years, says 3 years. Like if you used it for 3 years, that appears to substantially increase your risk. We now have new research that is associated that instead with the quantity that you've taken. And so if you've taken under 500 grams over time, that was associated with a 12% risk of eye disease. If you took 500 to 1,000 or maybe 1,500, it was 30%. If you took over 1,500 grams, it was a 42% increase. But now we know, and I talked about this earlier in this meeting, we have our first patient who received it in bladder installation, who has eye changes and bowel changes, and patients who got it by injections for arthritis also are showing those changes. Okay. So what started out as, how could this even happen, became oh my God, this is real. Patients immediately started contacting attorneys. Thousands of lawsuits were filed. The company to date has paid $43 million so far to patients. The lowest payout that I've seen is $250,000. The highest payout that I've seen is $1 million. We have patients now who are blind from it. So it was one of the patients who, and I won't say her name for her privacy's sake, who had just gone through all the eye lawsuits, and she had put off her colonoscopy. And then she finally had her colonoscopy, and they found polyps. Weird. They removed the polyps. Wasn't cancer. Go back in a year later or 6 months later, more polyps. Biopsy them again. Go back later, another colonoscopy. Her bowel is covered with polyps, polyposis. And she's a very, very smart woman. So she called me and went, is there any research that shows that Elmeron is associated with all these polyps growing in my bowel? And I went, I don't know. So I emailed Dr. Jane at Emory and said, Are you finding patients presenting with polyposis? He said yes. So then this patient went back and started circulating online to the various support groups, and she found a bunch of patients who not only had polyposis, but who had had colectomies. So most of the research is coming out of Emory, although there's still a lot more out there. I have a section of our website, right on the front page of our website, where you can scroll through blogs. I would encourage you to look at an article called The Tragic and Tarnished History of Elmeron, because it goes back into the FDA approval, which in my opinion should never have happened in the first place. It was denied by the FDA for 5 years. And then it got approved, and we don't really know why. But that research is now emerging. And so our latest study is this study, which came out in July, so last month. And it was by the UCLA Stein Institute. And they followed 8 patients over a 6-year period after exposure to Elmeron. Patients had used the med an average of 25 years, ranging from 45 to 4,600 grams. 75% were found to have severe colonic polyposis, the uncontrolled growth of polyps in the bowel. Most had no clue. They did not know that they were affected until they went and they had a colonoscopy at the age of 50. 3/8 were diagnosed with inflammatory bowel disease, and 3 of the patients had a partial or total colectomy. So we are having, Lisa, more and more patients who are just like you. They were on the Elmeron, but they got this bowel issue that was very, very severe. They had a colectomy. They thought they were separate and distinct issues. And it turns out there is a robust data that shows that Elmeron can affect the bowel. And we have case studies and articles that go way back that show that a patient taking Elmeron can have severe inflammatory bowel symptoms and findings when they look in the bowel, confirmed by biopsies. When they stop the medication, generally the bowel heals until it passes that point kind of no return and goes into structural changes in the bowel tissue itself. So the question then is, why is this polyposis occurring? Why would a medication cause the uncontrolled growth of polyps? And there was an article, and I don't remember which one, it was one of the recent ones, probably in the last 6 months, that talked about this, the shape of the Elmeron molecule, pentosan polysulfate, is very similar to another sulfate that is used to deliberately damage the bladder. So, I'm sorry, not the bladder, the bowel for research. So the assumption is that there's something about the structure of the medication that is just much more harmful to the bowel for one reason or another. So the theory was, and again, I don't remember where I read this, so don't quote me on this, is that the polyps are coming from the bowel just trying to repair itself every time it's damaged by the medication, if it's damaged by the medication, and it becomes this funky healing process. So that's kind of the best guess we have as to why polyposis is happening. I should be launching maybe in a week or two our new patient registry where we're trying to develop the data on Elmeron and bowel issues so that we can present it to the FDA to try to get the black box warning expanded to include colonoscopies. This latest paper from UCLA ended by saying that they believe that every patient using the medication should have frequent colonoscopies to monitor the health of the bowel. And they believe that because the effect is irreversible with the colectomy, that perhaps the FDA should evaluate or reevaluate its approval. Should it even be on the market, knowing what it's doing? And the heartbreaking thing here is it is widespread used in Europe, and they're just not letting patients know of the risk. We're like the voice in the wind here. I literally was begging the European IC groups to start educating patients about this because the research is solid. It is. So if you want to talk about it, feel free to give me a phone call this week. This is a big deal. And lots of patients have gotten a lot of money for their retinal damage. And you can be one of those patients. You could potentially sue. And I can give you that information if you want to give me a phone call this weekend. Our phone number is at the top of our website, but it's 800-928-7496. Feel free to call, and I'd be happy to talk to you a little bit more because I am having this conversation with newly diagnosed patients several times a week right now. And I'm really, really sorry. There are just so many issues. Let me get the link to this article that I wrote. It's based on an investigative report that was done that included Elmeron and Elmeron's FDA approval. It's just nothing short of astonishing. So hold on a second. Let me find this. I will also say that I had one patient call who had an offer of $50,000 who was nearly blind, and she called me to see if that was reasonable. And I said, I don't believe that that's reasonable. I believe that if you suffer eye issues, the company should provide lifetime eye care. They should pay for every eye exam. They should pay for every treatment. And they should pay for the help you might eventually need if you need somebody to drive or read for you. Here. Wait, what happened to the article here? I think this is the most important story of my career, to be quite honest. And I'm not backing away. And it's difficult because you're taking on big people. Big, scary people with lots of money. Kelly says, in your opinion, do you think E-string will work better for atrophy than topical estrogen I've been using for the past few years? Urogyne gave me a prescription for it and having it put in this week. I found E-string to be very annoying, personally, because it kept falling out. And I have to wash it off and stick it back in. I was not happy with that. Once it fell into the toilet, I was really not happy with that. But the disadvantage of E-string, more importantly, is that it doesn't give you the flexibility to put estrogen cream on your vulva or at the entrance to your urethra. I mean, if it works for you, great. It's not very popular. I think Vagifem is more popular if you just want a simple, easy something to insert. But again, the cream gives you flexibility, and that's important. Like if your vulva's hurting because it's dry, you can put the estrogen cream right on the vulva. Joanne says, because of listening to you, I asked for estrogen cream with lidocaine in it. Finally got the estrogen 0.01 and lidocaine 10% vaginal cream. I was a little hesitant to start it. That's what they gave me. And I loved it. I mean, what are you hesitating? What's the hesitation here? What are you worried about? The lidocaine is just a numbing agent. It's just going to calm nerves down. So is it the lidocaine that's scaring you, or is it the estrogen that's scaring you? Chimera says, somewhat off topic, but I just had a scientific article pop up talking about the retina's hidden cleanup system. I need to read it, but I remember a doctor talking about buildup on my eyes. Okay, so if there is an optical lymphatic system that helps trash out the eye, it could impact some macular dystrophy patients. Well, the problem, Chimera, the problem with that is that this is atrophy. The retina is atrophied. And once the retina is atrophied, that's pretty much irreversible. So if the assumption is that we can flush out the medication before the atrophy occurs, that's a win. But once the atrophy has occurred, I don't see that making a lot of sense. But it's all very, very new, and we got a lot of the best eye doctors in the world studying this, and they may have something that we don't know about yet. Maybe there will be a treatment. I don't know of any right now. There's only been one published study that showed one treatment that might have helped one patient. It's a very, very sad situation all the way around. Lisa said she went through 8 years of hell before she had the total colectomy. I still have to go back every year and a half and have small pockets removed from my rectum. I'm not surprised, honey. Hey, Kayleen's birthday is today. Happy 32nd birthday. Happy birthday to you. Happy birthday to you. Happy birthday, dear Kayleen. Happy birthday to you, and many more. Although you can do the birthday dirge, which is what my brother always sings to me, which is happy birthday, oh happy birthday. Toil and struggle, death and sorrow, today is your birthday. That's what my brother sings to me every year. I'm not singing that to you. I'm singing the happy, happy birthday. Hope you have a good day, honey. That's exciting. The birthday dirge. Catherine said, it's amazing that Elmeron is still being prescribed. I'm just glad it was never offered to me. Thank the Lord. Yeah, I don't understand it. I mean, what I'm hearing from patients who have urologists who are prescribing it is the urologists are basically saying, well, I've never had a patient with problems, therefore I think it's safe. But I will tell you, one of the top IC doctors who's retired, but he sees patients once a week at a small clinic now. He emailed me and he said he just had his first case of polyposis. And somebody had had their bowel removed. And he was shocked. Like, it's real. It's real, guys. It's real. I never took it. Some people say, well, why didn't you take it? Well, I'll tell you exactly why I didn't take it. Remember, I have a degree in drug development, pharmacology. It's a really rare degree. And my thought was, now, wait a second. If you swallowed a Band-Aid, would it come out the other end a Band-Aid? And the answer, of course, is no, we have digestion. And so the real question is how much of the medication is destroyed by digestion versus how much of it gets to the target organ where it's supposed to help. And the company released what they called their bioavailability research studies, which showed that 92 to 93% of it was destroyed by digestion. So very little of it actually made it to the bladder to be helpful. And so given the fact that each capsule is 100 milligrams, right? So you have to assume that only 8 milligrams, 7 or 8 milligrams would actually make it to the bladder to be helpful. So is that enough? And the answer, of course, is probably not, which is why patients, the drug manufacturer's recommendation was to take 3 a day, which would be 21 milligrams of medication in the bladder. And some doctors believe it's even less than that, maybe 5%. So it never made sense to me. Its method of action and so I remember when it was bought by Alza Pharmaceuticals, companies who specialize in what we call drug delivery systems, I thought, okay, they're going to work on it and improve the bioavailability so it actually get to the bladder in quantity. And they didn't. So the other thing that happened that was historically really significant is that there are some doctors out there who told patients to take 6 or 9 a day. Okay, so the company years ago, back in the 90s, I think it was in the 90s, did what we call a dose ranging study. So they were testing the effectiveness of 300, 600, and 900 milligrams a day. And it was a formal study with patients. And obviously, they were hoping, I'm sure, that they could say that the more a patient took, the better the effect. But it turned out that was the opposite of what happened, that the patients who took less, did better than the patients who took more. And then there was a study of 100 milligrams a day, 200 milligrams a day, and 300 milligrams a day. I don't remember the exact results of that study, but again, I had one of the top doctors say, well, and that study showed that it wasn't particularly helpful either. So the heartbreak here is that the research showed that the higher doses were not as effective as the lower doses. And yet there were some doctors who were telling patients to take a lot of it. And now that we know that the more you took, the greater the risk of bowel issues and eye issues, it's just really heartbreaking that they didn't follow the research. And you just have to wonder why. Why didn't they follow the research? And I think it's a follow the money, honey kind of situation. I don't know. I just don't know. What we do know now is thousands of patients are having changes in their vision. And I think, personally, I believe far more patients are having bowel issues. We knew it was approved in 1996 and 1997, if I remember correctly, there were 400 reports of adverse events filed with the FDA related to the bowel. And diarrhea. And I'll never forget, I had somebody called me. It was a man who'd been taking it for a year, and he just suddenly developed horrific diarrhea, inflammatory bowel disease. And he called me and said, is this connected to the Elmeron? And this was like 97, like a year after it was approved. And I said, I don't know. What I've been told is that it's from the capsule, and the company said, take it out of the capsule. But now we know that's not necessarily true. And I don't remember who advised that, but lots of people, old timers, remember that. I remember that. It's a bad situation all the way around. And I don't want patients to be depressed by it. I want patients to be angry, be angry. I posted the article, Tragic and Tarnished History of It. Read it. If you're not angry after you read that article, yikes. And let that anger drive your decision making with respect to if you want to sue or not. Everybody's different. Okay. Christina said, at some point in time, I'd like to see you do a broadcast about IBS and link to IC if there's any research on it. I have IBS on IC. IBS complicates, causes more pain. It would be nice to understand why and how it affects the bladder. We talk about that all the time, Christina. That is the widespread pain phenotype. I'm an IBS. I used to have very, very severe IBS. In fact, I had the IBS before I had bladder pain. And that's all now connected to something called chronic overlapping pain conditions, which is basically injury to the central nervous system. That all these pain conditions are being driven by overly sensitized, sensitive nerves. So about 15 years ago, a wonderful research team came together called the Chronic Pain Research Alliance. Their job was to try to understand why some people go on to develop these multiple pain conditions. And listen, because I had them all. I had IC, IBS, vulvodynia, TMJ. I had migraines for a while. Very sensitive skin, wicked sense of smell. These are all driven by the central nervous system. So what they found in that research is that patients with widespread pain have a brain stuck in fight or flight. The 24 hours a day, 7 days a week, the brain is behaving as if their life is at stake. And that is what causes this body-wide nerve sensitization. And therapeutically, our priority now for patients with widespread pain is to focus on systemic therapies that calm the nervous system down. It's very, I talk about it all the time. And we can do a special session on that too. Lisa says, I'm having to see a low vision specialist right now. The insurance does not cover. Fortunately, I can't afford, not forever. Someone has to drive me now. It's just my glasses are $2,000. Yikes, girl. Oh my God. See, and that's exactly why talking with an attorney who specializes in cases like this would be reasonable to get these expenses covered in a settlement. Christina said, I'm 70, was diagnosed with IC in my 40s. My doctor at the time prescribed it for me. Thank God I did not take it. Yeah. Again, they mentioned it to me too, but I did a hard no. My gut and my training just said it didn't make sense. Kayleen said, I'm counting down until my bladder Botox. I had to go to the ER Tuesday. Girl, because I had a bad reaction to my new migraine meds. I didn't even have to pee much, and I'm really trying to work on holding for 30 minutes. I felt a big gush, but a good thing I was wearing a poise pad. I should not be like this as a childless 32-year-old. Thank you for singing. That made my day even better. You're welcome, honey. I wonder if having migraines or a reaction like that just made me really weak. Yeah, well, it would have been, I think it would have. And that's like a big deal, hun. And I will tell you that, I'm 66 now, and granted, you are so much younger than I am at 32. I wear a mini pad every day, an organic cotton mini pad every day, because you know what? A little drippy action here and there happens now. Not a lot, but I will tell you a couple of times when I've been very, very ill, like with COVID, I think it's happened twice now. I just lost control. I was in the bathroom already and it just started coming out. And so I associate that with being very, very ill and just not having a happy body and a happy bladder and just being very, very ill. It's crazy. Sherry said, I took Elmeron for 2 years in 2014, 2016. You got the eye issues in 2021. But I think the time has elapsed to make a lawsuit. The time has expired. No, the time hasn't expired. it's the statute of limitations combined with finding an attorney, because basically all those original cases, most of the original cases are over, and those attorneys are not interested in representing new patients. But if you were, the question is when were you diagnosed, and what's the statute of limitations in your state? So if the statute of limitations in your state is 2 years, you are out of luck, my friend, because you should have filed by 23. But if the statute of limitations is 5 years, you can still file. But you got to get on it and do some research. I don't know what the statute of limitation is for your state. Christina said, yes, I do have widespread pain like you described with the IBS, and was suspecting that I have the problems you described. So it would be interesting in help finding out some of the therapies to help. So systemic therapies, I mean, you approach it a couple of different ways. So concept number one is you're stuck in fight or flight, and we got to get you out of fight or flight. And there's really good news, is that's actually remarkably easy to do. You can use breathing techniques. You can use tapping. You can, I mean, there are just a number of techniques. You just have to Google it or go to YouTube on how to calm your brain down and get yourself out of fight or flight. But it's a labor of, it's a daily labor, because usually fight or flight's been there for a long time, and it's basically a memorized issue. So what the research shows is that 80% of the children who grow up to develop chronic overlapping pain conditions, there's a major physical injury, like being hit by a car, being run over by a car. Worked with a gentleman who was run over by a bus and had a shattered pelvis, and there you go. He was been dealing with it ever since. 14 days of pain will put the brain into a constant state of fight or flight. For the other 20%, it's a history of abuse or bullying. And that's very, very common in the IC patient population. And so, and again, the theme is growing up with an alcoholic parent, a violent alcoholic parent. So a way to look at this is, how does a child's brain respond to trauma? Well, your brain stem is the most primitive part of your brain. There's no cognition happening in fight or flight. Your brain stem has one job: to save your life. So what it is doing is it is 24 hours a day monitoring your sensory input. What do you see? What do you hear? What do you smell? What are you tasting? And what are you touching? If it senses a threat, it is going to take charge. The sympathetic nervous system takes over control of the brain. It turns on a structure called the amygdala, which is the fight or flight center with the control and command center for fight or flight. And normally, fight or flight is short term, that after the threat is gone, 2 hours later, fight or flight is supposed to turn off. That doesn't happen in patients with widespread pain. We're like stuck there. We're stuck in fight or flight. Sorry, my incision just zapped me. Darn it. Okay, so why does this happen? It's persistent trauma over time. It is that child's brain. Let's say you grow up with a alcoholic parent. Okay, and you've got a 5-year-old who is already, their brain already knows there's a problem. Mom or dad starts drinking, people start yelling, they get hurt. So that brain stem and their central nervous system starts to get very vigilant. They are listening for the car at the end of the day when that parent comes home. And as soon as they hear it, fight or flight kicks in. And then they're listening for the back door to open. Then they're listening for the snap of the beer cap. So it's intense vigilance, because that brain knows, the child doesn't know, that brain knows that those sounds are associated with increased risk of danger. So you got this incredible hypervigilance happening, and then they know that when daddy starts drinking, bad things happen. So then that child's going to go hide. And we have had fathers break down bathroom doors because they're so drunk, they're so angry that their child is hiding. They break down the door and beat up that child. Now imagine how that brain is going to respond to that if that happens every day for 10 years. Of course, fight or flight becomes an appropriate response to persistent daily trauma. The challenge here, and I had this too, hon, except I didn't grow up with an alcoholic parent. I had somebody in my neighborhood who attacked me all the time, who raped and murdered people. You know, thankfully, he was young and I was young, so he didn't know how to rape and murder me when he attacked me, but I ran for my life every day for 10 years. And that is ingrained in my soul. And that is the foundation for my fight or flight and for all of my chronic overlapping pain conditions. But here's the deal. It's over. I mean, it ended when he went to jail when I was 20. Granted, in and out of jail a couple of times, but my life had not been directly threatened other than once or twice, maybe in 40 years. I worked for the feds for a while. It was a dangerous job, so my life was threatened there for sure when I was like 22. But your brain remembers trauma. It just remembers it. All it takes is the sound of a beer can opening, and it can bring it all back. All it takes for me is somebody saying one word. I'm not going to say what that is. And it brings it all back for me. So we have to work hard to retrain our brain that we're safe now. We can defend ourselves now. The abuser is long gone, and many times they're dead. They're just dead. And yet our brain doesn't recognize that. Our brain is going, be safe, be safe, be safe, be safe, be safe. And one of the things that happens when you have been a victim of childhood trauma is that you start saying no to every invitation. Every invitation. It's a, hey, Jill, you want to? No. Like they can't even finish the invitation. I don't even know what they're asking me for. And out of my mouth pops no. And it's very frustrating because I literally wanted to accept every invitation. And I said no to every single invitation other than from my two best friends. And even then, I've still said no. And I never understood it until I went to an anxiety management class for the first time. And the cool thing about that class is when I actually met other patients with it, it immediately took the shame away because it was very clear that we were all normal people who had simply had something bad happen to us. Okay. And so like immediately the shame fell away. It's like, oh my God, that happened to you. That happened to me too. Okay. Put it in context. And then the instructor just said, how many of you say no to everything? Then we all looked at each other, like 30 people in the class. Every single person raised their hand. And he said, do you know what that is? We're like, no. He goes, that's guarding. That's your brain saying, stay home. It's safe at home because you've been through trauma. It's like, oh my God. Oh my God. At least now I understand it. And the other thing that's just so interesting is that Like, I have been to Europe, I have been to Hawaii, I have family in Hawaii. I never enjoy myself on a trip. I spend the whole trip obsessing about getting home. Like, I can't wait to get on the plane and come home. And it is just the dominant thought in my brain whenever I leave home. It's get home. It's safe at home. That's the effect of childhood trauma. And this is where, number one, no shame, no blame. We did nothing wrong. We were just hurt badly. We have to work with somebody to retrain that out of our brain. That we don't have to say no. We don't have to guard anymore. I have a video on our website in our main Living with IC videos. It talks about the class I took, which absolutely changed my life. And I have not had a panic attack since I've taken the class. I will say I do not like traveling at all. I am a homebody. And like, we had a family event yesterday that was an hour away. I didn't go. But I didn't go because of that. I didn't go for another reason. But EMDR therapy is probably the most exciting thing that's happening right now. It is not talk therapy. It's not about going to a psychiatrist and spilling it all out and talking about who, what, where, when, why, which I hate doing. And understand, I didn't talk about my trauma for the first 40 years of my life because I didn't understand the role it played in everything. Now I know it's the foundation for everything I've suffered. So I talk about it all the time. But EMDR therapy is all about reversing the trauma response, reversing the fight or flight, reversing the panic attack. And it uses tapping or eye movements. And it's fascinating because all it's doing is it's just taking the energy out of the trauma. I did it over Zoom for 5 weeks and it changed my life. I did it 2 years ago because of my trauma from breast cancer and breast cancer surgery. And we worked through the breast cancer trauma, and then we worked through the death of my parents' trauma, and then we worked through IC trauma, and then we worked through business trauma. And at the last appointment, she's like, well, it's our last appointment. What do you want to work on? I went, let's bring out the big guns. Let's go back to what happened in childhood. And it was wonderful. And it was easy. It was so easy. We did it over Zoom. So think about EMDR. E as in Eric, M as in Mary, D as in dog, R as in Robert. EMDR therapy. Because we just have to teach our brain consistently and persistently to reverse that nervous system memory from stress to calm. It's fascinating. I think I might write a book about, people keep asking me to write a book about what I went through, and I'm getting closer maybe to doing that because it's really common. You think about all the trauma that children are experiencing today, like all the children who have been at schools where there have been shootings. It's gonna affect some of them for the rest of their life because of what it's doing to their central nervous system. Like, oh man, do not even get me started. What a violent society we live in. So many children, and just throw in the trauma from the internet. Oh my God, it's crazy. Like, don't you just want to disconnect? I just want to go back to the 70s. Although I understand that the 70s were not necessarily good for other people. I totally get that. I just want to be in a simpler time where everybody got together. Nobody was fighting about politics. Money was not a big deal. We had a middle class. People had jobs. Gas was 29 cents. I filled up my car yesterday and it was $6 a gallon. I paid $60 for 10 gallons. Christina said, thank you for what you do. Thank God for you, because so many of us would. Thank you, honey. It's just like I am so determined not to let my lifetime be a waste, because I didn't have children. I am not married. And I'm going to tell you right now, one of the reasons why I'm not married is it's very hard for me to trust men because of the trauma that I went through with men. And so I see undeniably how this trauma affected my life. But damn it, I'm not going to my grave victim. I'm going to do something productive with it and help others. My grandmother taught me, you got to earn your angel wings. And I was like, Grandma, how do I do that? You got to help somebody every day. Every time you help somebody, it's a feather in your wings. And that's been the model of my life for the last 50 years. Allison said, hi, Jill. I'm a longtime IC patient and EMDR therapist. People can find an EMDR therapist at emdria.org, which stands for the International EMDR Association. Allison, did I get anything wrong? What would you add to that? I love people who tell me, who make it better if I get something wrong. So if I didn't describe anything correctly, please step in and I will read it. I want to get it right. And again, guys, I just got to be really clear. I have a master's degree in psychology. I was going on for my doctorate in psychology when IC happened to me. And I was a presidential fellow. Listen, I was a really good student. I was a straight A student. And even then, I couldn't talk about what happened to me. I don't think I started talking about it until my early 50s. That's how badly childhood trauma affected me. I refuse to carry any shame over that now. It was never my fault. It was a result of somebody who was very mentally ill. And what's so interesting is one of my tennis buddies, back when I was playing a lot of really competitive tennis, this guy was gorgeous on the tennis court. Oh my God, he looked like Bjorn. He hit the ball like Bjorn Borg. Just the most beautiful tennis player I have ever seen in person. And I loved playing with him. And he had no male friends. None. Here is like the top male tennis player in Northern California. No male friends. He could only talk to girls because he was stranger abducted as a child twice by the same man. And his mother did not believe in therapy. So here you got this young boy who was kidnapped and raped twice. And he never got therapy. And it's heartbreaking because you could definitely see out. And he had the same thing. He said the same thing to me. He said, I've missed out on so much. I've missed out on a normal life. No male friends. And severe anxiety also. Michelle said, a simpler, kinder time. Amen. Yeah, definitely. Sherry said, yes, but I only had 2 polyps at 55. I'm 67 now. Allison said, I think you described it well. It is a brain approach that provides the most relief I've seen in over 30 years as a therapist. Do you think it should be able to get you out of fight or flight and also not get triggered? Yeah. See, like my triggers are so much better now. It's really interesting. I just feel a level of calm that I've never felt before. What I haven't been able to do is stop the no to invitations. I'm getting better at it. I'm doing more, but that, your brain, again, this is not cognitive brain behavior. This is simply brainstem behavior. This is subconscious. This is just our brain just trying to protect us because we were hurt at one point in time. So it's wonderful to have that context now. And I was thinking about that this morning. I was just listening to a book on tape this morning, or a story on YouTube this morning. And it was about a young woman whose husband had passed away, and her family basically said, "We don't want you anymore. You need to go." They gave her the lease for, a rundown house that's barely standing, and how she goes to that house and fixes it up and makes a home for herself. And I kind of wanted to talk about that at this meeting because I think we can't let others limit us. We have the power to do more than we realize that we can do. There's a sensation or a sense that I've got this incurable disease, therefore I must give up. I've got breast cancer, therefore I must give up. And it's like, no, we're not going to give up. We're going to fight. We're going to fight for our life, and we're going to build the life that we deserve with the people who treat us the best, what we deserve. They treat us well. And it was specifically about how she found like peace and comfort making her home, not relying on anybody else, not relying on a partner. Like, she did it for herself. And that just really resonated for me, because that's what I'm doing right now. Is I'm finally, after years of caregiving and decades of caregiving and cancer, I'm just like, okay, I'm making a nest. My home is my nest. I am perfectly happy in my home. I'm going to do everything I can to make this a happy place for me. And then, when I'm there, am I willing to be in a relationship with somebody? Maybe. But not right now. I'm still trying to figure out what the life I want to lead first. It is what it is. I have somebody who wants to date me, and I'm like, no, I'm not ready for that right now. I'm just figuring out who I am post all the trauma. And that's fine. I like it. I like what's happening right now, despite all the medical shenanigans going on. Allison said, 2 good books on it are Getting Past Your Past by Dr. Francine Shapiro, who is the founder of EMDR. And another one is Every Memory Deserves Respect by Deborah Korn and Michael Baldwin. Oh, that's interesting. You're right. Every memory does deserve respect and context. And I really believe that trauma left unaddressed is a trauma that will haunt you. The more we can address it early. I mean, I wish that I could go back to when I was a kid. I should have had therapy back then after I was attacked. It just didn't happen. Therapy was considered shameful in the 60s and the 70s. It just was. All right. Here, I got to shake it out. Hold on. My tush is sore. I bought this dress in my 20s. I save the things that I like. I have been wearing this dress off and on for 40 years. And it's holding up well, if I do say so. It's a little stretched out, but I'll take it. All right. Let me go back to YouTube here. Joanne says, I'm just not very brave. If you say it's okay, I'll do it. Between GBS and IC, I get fearful of the Guillain-Barré syndrome and 5 months in the hospital, and you had a Foley for 5 months. God damn, girl, that was a wicked. You know, Joanne, I think that here, let's look it up. I mean, you need to talk to your pharmacist about this. Is there any incidence of Guillain-Barré with estrogen therapy? Let me just search this. There's no direct causal link that shows that estrogen therapy causes or treats Guillain-Barré syndrome. Hormonal factors in estrogen play an immunomodulatory roles that may influence autoimmune responses, but clinical data specifically addressing estrogen therapy during or after GBS diagnosis are sparse. Okay, so let's see if lidocaine has been known to cause it. It's actually used for patients recovering from Guillain-Barré, but it only treats localized discomfort and not the effect of the underlying autoimmune disease. So, I mean, I would go talk to your pharmacist and let's see what your pharmacist has to say about that, hon. I mean, listen, you went through hell. I completely understand your hesitation. Completely. The data looks fairly good or very good, but I think you need some comfort from a pharmacist. So talk to the pharmacist, talk to your doctor, see what they say, and ask them specifically to research estradiol, Guillain-Barré. Let's see what they say. Chimera says, Dr. Jane at Emory is my hero. They finished up a study to help us find apps or meta glasses that could help us with our vision loss. You talked with me about the study, and you are my hero for speaking out. Thank you. He was looking for a GI doctor to do the research on it for a couple of years and finally found one to work with him on it. Yeah, he just brought on a new resident who I've talked with a couple of times who's studying the polyposis specifically. Dr. Jane said he has an IC patient that was facing colectomy due to damage. After being his patient for about a year, they are not dealing with the GI problems and didn't have her colon removed. Oh, okay. Well, and that's not surprising because we have multiple studies that show that the bowel can heal after stopping Elmeron, maybe. So maybe that's playing a role. And you were taking 6 a day. They later lowered it. Okay. She says, when we were researching all my meds, trying to find answers, there were hundreds of people talking about stopping it because of the GI side effects. So they never took it long enough to see if it helped. There were a few of my medications that people went off of due to tummy side effects. So there's no reason for me to imagine the things that are showing up now. Boy, our bodies are complex, and they just gets more complex as we get older, too. That's the thing. Allison, if you're still watching, thank you, honey, for sharing that. I really appreciate that very, very much. Michelle said she went from 1 polyp to carpeted in 5 years, so please stay on top of your colonoscopies. Yeah. Yep. Crazy time. Let me just take a look here. Let's see if there's anything new in the National Library of Medicine. Hold on. Because it's like literally every other week there's a new Pentosan Elmeron study. May 26th, characterization of pentosan polysulfate maculopathy with fluorescent lifetime imaging. There's a couple of new studies. Risk factors for pentosan polysulfate from Canada. Well, hold on. And this was published out of Emory in the Canadian Journal. In total, 187 patients underwent screening. Risk of toxicity was dose-dependent, with those in the greatest exposure quartile of more than 2,000 grams showing the greatest risk. Other factors associated with risk included cumulative dose per body weight, female sex, older age, and inflammatory bowel disease or IBS. In low exposure cases, those with maculopathy were older, had longer pentosan exposure, a greater dose per body weight, and a lower body weight. Oh, that's interesting. The prevalence of toxicity among pentosan users at Emory is estimated as ranging between 3.8% and 24.5%. They conclude this comprehensive screening study corroborates the risk of pentosan maculopathy is primarily driven by cumulative exposure, but also suggests a possible role for other factors, including age, sex, and body weight. These findings have global public safety implications and may help inform dosing guidelines and screening protocols. Oh boy. Here's an interesting correction. Post-marketing safety of pentosan, a 21-year pharmacovigilance analysis of the FAERS database. Ooh, let's look at that. What is that? It's just corrections in where a doctor worked. All righty. Yeah, here's this. The latest one is in July, and that's this one that I talked about already. Oh boy. Hi, Deirdre. How are you, hun? How's your IC today? Lisa says, without Christ, I wouldn't have made it through this journey. Thank you for all the work you do. You're very welcome. Faith is everything. At least for me, it is. That's for sure. Yeah, I'm sorry, Chimera. You know, you had a journey. You definitely had a journey. All right, guys. So now we've been going for 3.5 hours. Woo! Oh, it's hot here. Again, I just need questions. So Deirdre said, I have MRSA from an infection. Oh, honey, I'm so sorry. Multiple drug-resistant Staphylococcus aureus? Yikes. Where, honey? Where's the infection? Joanne says she uses lidocaine gel on my feet for nerve pain. Still do. 0.8 gel equate aloe sunburn. Okay, so we know your body is okay with lidocaine then. Girl, how'd that happen? In your bladder? You have MRSA in your bladder? How do you I mean, were you swimming? what do you think triggered that? Like, did you go to a lake or a swimming pool or the ocean? Or did you have a procedure in a medical facility? Because MRSA is easily a nosocomial infection that you get from potentially catheter being put in your bladder or something like that. That's always possible. No, you have an SP tube? Well, you know, they have mapped some infections and biofilms literally moving from up the catheter on the surface of the catheter, where they migrate from outside to inside. Like they just like travel. They're like on a road trip. So, oh, you had Botox. And so the Botox gave you urinary retention, which is why you have the suprapubic catheter, right? So you are a living testimonial to the risks of Botox. And now, unfortunately, you have acquired an infection. How are they treating it? Like, what med are you on? Are you on vancomycin? So multiple drug resistant infection, guys, these are big deals. I mean, we call them superbugs, right? They're usually resistant to multiple antibiotics, so killing them is hard. So Deidre just said here, the antibiotics they just put me on are not working. Okay. So you need to call your doctor like right away. And is this your first antibiotic, or have you tried several so far? Well, macrobid for MRSA? Broad spectrum drug resistance is very common because medications like macrobid are used so often. So generally, now I'm not a urologist, or an infectious disease specialist, so I could get this wrong. They would start with the easy stuff before they go to the harder stuff, because the more you use an antibiotic, the greater the risk that the bacteria is going to become resistant to it. So they generally start you with something like macrobid. If that doesn't work, they're going to put you on something a little bit more aggressive. If that doesn't work, they're going to put you on something a little bit more aggressive than that. But girl, you need to be on this and communicating with them big time. Like literally send them a message tonight and say it's not working, because we don't want you to go septic. So really communicate with them how you're doing, because they'll want to jump on that normally. So depending on how long you've been on it, yeah, but don't just try to fake your way through this. MRSA infection of the bladder is a fairly big deal, my friend. I called and they said my only other thing is IV antibiotics. Hell yeah. Get your ass to the hospital and get your IV antibiotics. This is about saving your life. MRSA infections that go septic are dangerous. So, I had pneumonia last December. I was on 3 antibiotics for that. Man, that was a beast to kill. I think we first did amoxicillin, did nothing. Then they put me on Augmentin, and it brought it down maybe by half. And then they combined Augmentin with a Z-Pak, azithromycin, and that's what finally killed my pneumonia. And I had it twice. And guys, we have a lidocaine product in the IC Network shop too. I think by Curus, just a very, very good lidocaine. You can't take anything like amoxicillin. Okay, so they're going to have to probably do one of the newer ones. But again, don't be passive here. Man, be squeaky wheel. You need to let them know right away that it's not working. I mean, I was so sick with pneumonia that I mean, like it started on a Monday, and by Friday, I was massively dehydrated in AFib and had to call an ambulance. You know, and then we get to the hospital and like, yeah, you got pneumonia. It's like, okay, what do we do next? You have flank pain so bad. Yeah. I mean, like, to me, I would be at the ER like tonight. If I were in your shoes with flank pain that bad and the antibiotic isn't work, I just bought myself in the car and go down to the ER and just say, hey, I got a MRSA infection. The antibiotics aren't working. I need IV, and just get it done, girl. Just get it done. That's what I would do because I've done that before. Man, if I'm scared, you know what's my rule for the ER? If I'm scared, if I'm very, very ill, I don't hesitate. I go. I mean, I had a post-op infection from my. I had it on this side, and you can see it. See that spot right there? That was a post-op infection after my mastectomy. Crazy. Crazy, crazy time. I wish you luck, honey. You know, what is it? I don't know where you are right now. It's 4:30 here. It's 7:30 there on a Sunday. I mean, if you're thinking you're going to do it, you could go tonight. It'd probably be fairly full, but I wouldn't let that stop me. But the best time to go to the ER is like 5 in the morning, which I've done. I have done that. Listen, we pay a lot of money for our health insurance. By golly, we're going to use it. And every time I've been to the ER, I've been treated quite nicely. Quite nicely. And they're like, we're glad you came in. You needed to come in. Like, I'm not an idiot. I know when things are not going well. Good luck, hon. Good luck. All right. Well, you know, so we've been going for 3 hours and 33 minutes. I am happy. Let's do a last call for questions. Last call for questions. I want to thank you for those of you who are listening after the meeting. Thank you for listening this far. Really appreciate it. If you find my meetings helpful, please think about becoming a member of the IC Network. $25 a year, you'll get our magazine. It's a win all the way around. We do have a new store that's coming online soon with new member areas, hopefully by the end of the month. So lots of things happening out here. Good things. Good things. All right. I think we're done. So I want you all to have a great week this week. As always, if you want to talk, feel free to give me a phone call. Phone number, 800 numbers right at the top of our web pages. I do have a new web page. We just launched ic101.org to cover all the IC 101 books. Oh, I got to take that down. I have a new cover for that book. Oh, man, I got to take that down. So that's kind of interesting, the stuff that we're doing over there. Just a lot of things happening right now. So, all right. I'm going to say goodbye to YouTube first. I'll see you guys later. And Donna, if you're watching, call me. I want to talk to you. I miss you.